Hi students, good morning. So today we'll be going with a MAHA revision for ophthalmology for your Jan 2026 exam. Before we start, I want all of you to have faith in yourself that okay, you have prepared. Now it is time for quick revisions, for going for previous year questions, and you will always feel that it is impossible until and unless you clear the exam. You are braver than you believe, stronger than you seem, and smarter than you think. So with this, before starting with the class, I would just like to tell you about our online live batch that is starting for your starting from June for the June 2026 exam, that is starting from 15th of Jan. So all of you who have your juniors, your friends who are preparing for FMG, you can recommend it to them. So let's start with the first entity or the first topic of the day, that is lenticonus anterior. This is how your lenticonus anterior will look. This is your lens. It is seen in Alpert syndrome. Then you have lenticonus posterior, that is seen in Lewis syndrome. A anterior, A Alpert, and KLMNOP. So posterior is seen in Lewis syndrome. Then if we talk about ectopia lentis, so ectopia lentis, we know it is the displacement of the lens from its patellar fossa. Most common cause is blunt. See, it is going to be most likely a 2.5 to 3 hour session. So most common cause of ectopia lentis is blunt trauma. This is how your ectopia lentis look. This is the margin of the lens and it has displaced from its normal position. If we look at Marfan's, this is a repeated previous year question. In Marfan's, you draw M like this. You are going to have a superotemporal dislocation, and in homocystinuria you are going to get opposite to that of Marfan's, that is inferonasal dislocation. In wheel marchesani, something that has wheels would like to walk fast. That person would like to be anterior. So in wheel marchesani you have anterior. Easy way to learn: M, draw an arrow like this, and you have superotemporal in Marfan's, opposite in homocystinuria, anterior in wheel marchesani. So this is very important. In Marfan's, you will not be directly asked the question that what is the direction of displacement. You will be given that there is a male who has increased arm span ratio, who has got flexible joint with some heart defects. In this person, the ectopia lentis is observed. What is the direction of this ectopia lentis? So this is how you get the question on Marfan's. Then congenital or the developmental cataract. Remember, most common risk factor is a maternal infection of rubella and maternal malnutrition of vitamin D deficiency. If we talk about the types that are important for your exam, this is how your blue dot cataract looks like. Multiple blue dots that are dispersed all over the lens. Then this is the most common visually insignificant congenital cataract. Yes, I am going to cover all the topics. So this is the most common visually insignificant congenital cataract. If we talk about the zonular cataract or the laminar cataract, risk factors are maternal malnutrition and maternal infection. These are more specific for zonular cataract. It is the most common visually significant. See, all of you have attended ophthalmology lecture, so this is just going to be a rapid revision for you. In case if you don't understand anything, you can ask me. Otherwise, we'll be just going with the quick points. Then zonular cataract is characterized by the presence of zonules. It is characterized by the presence of lamellae or spokes or riders. Now this is how your zonular cataract looks like. These are the spokes or the lamellae. Then total congenital cataract, it is characteristically associated with rubella infection. in which it is known as pearly white cataract. If we talk about the management of congenital cataract, that depends on two factors. Number one, density. Number two, laterality of cataract. So if you have congenital cataract that is unilateral but it is partial, just like blue dot, you will just wait and watch. What are you not able to understand? Anything specific? Just tell me. And then you have unilateral dense cataracts. So for unilateral dense cataracts, you will go for surgery. What happens if you don't do timely surgery? That will lead to stimulation, deprivation, amblyopia. So what is the most common complication if unilateral dense cataract is not treated on time? That is stimulation, deprivation, amblyopia. Then if you have bilateral cataracts, bilateral partial, again you can wait and watch. And if it is bilateral dense, then you have to operate within 4 to 6 weeks of life. Again, if it is not operated, then what can it lead to? It can lead to stimulation, deprivation, amblyopia. So this is how you manage congenital cataracts. Then moving on to acquired cataracts, what are the things that you are going to get in the question? You are going to get the history of blurring of vision for far, then is phenomena of second sight, colored halos, glare and frequent change of glasses. Colored halos, apart from acquired cataract, they are also seen in acute angle closure glaucoma and conjunctivitis. How will you differentiate? For conjunctivitis, you ask the patient to blink. If the halos they disappear, then they are due to conjunctivitis. For acute angle closure glaucoma and immature cataract, you will differentiate it based on Fincham's test. This is also known as stenopic slit test. So if the halos they break, they are due to immature cataract, and if they continue, they are due to acute angle closure glaucoma. This Fincham's test has again been a previous year question. Then what is the earliest symptom of cataract? Earliest symptom of cataract is your glare. Phenomena of second sight, why does it occur? Because what happens in cataract, there is nuclear hardening that leads to abolition of glasses for near, which you call as phenomena of second sight. This is your cortical cataract. This is your characteristic bread crumb appearance, or what you also call as polychromatic luster. Then this is your mature cataract. Everything is white, and if you see white with something like this, this is your sunken nucleus and this is your liquefied cortex. You call it as hypermature cataract. This breadcrumb appearance or the polychromatic luster is characteristic of posterior subcapsular cataract. If you ask the most common risk factor or the most important risk factor for subcapsular cataract, that is nothing but steroid use, be it in topical, be it oral, any form of steroid use. Then moving on to specific cataract, you see a snowflake cataract like this. This is seen in diabetes. This occurs due to the aldose reductase pathway. So what happens normally? Normally your glucose is converted into sorbitol via your enzyme aldose reductase. Then the sorbitol is converted to fructose via your sorbitol dehydrogenase. This is the normal pathway. But what happens in diabetes? This is absent due to osmotic stress. So what will happen? Sorbitol will keep on accumulating, and this accumulation of sorbitol will lead to moving of water inside the lens, that will lead to the formation of cataract. This is your diabetic cataract, that is characteristically snowflake. Then is myotonic dystrophy. This is your Christmas tree cataract. In galactosemia, you have got oil droplet cataract. You will just see a black dot like this. This occurs due to galactokinase and G-put enzyme deficiency. Then galactosemia, what happens is there is accumulation of galactose and galactylol. So if you ask what is the substrate and the metabolite that is accumulating in galactosemia that is leading to cataract, that is your galactose and your galactylol. But if you ask me about diabetes, so diabetic cataract is occurring due to accumulation of sorbitol. So this is important. Now is Wilson's cataract, sunflower cataract. This is your sunflower cataract. Apart from sunflower cataract, what is the other clinical sign seen? That is KF ring. What is KF ring? It is copper deposition in the Descemet's membrane of the cornea. How does it start? It starts superiorly, then inferiorly, and then it would cover 360 degree. If you look at this type of cataract, this is your traumatic or the star shaped or the roseate cataract. Then you have this cataract. This is shield cataract, which is characteristic of your atopic dermatitis. So these are the important points that you need to know in this slide. This is one of the very high yielding slides of cataract. Then if we talk about the management options, surgery type can be either ICCE, intracapsular cataract extraction. Site of incision is incision length is approximately 10 mm. Conventional ECCE, again site is limbus, again it is around 10 to 11 mm. SICS, site of incision is sclerocorneal tunnel. So you can say the site of incision is sclera. Incision length is somewhere around 6 to 7 mm. Phacoemulsification, it is cornea. Site of incision length is 2.8 to 3.2 mm. In MICS is micro incision cataract surgery. In this, the site of incision is again your cornea and the incision length is 2.2 mm. So this is the most advanced. Another previous year question that you need to know is FLACS. So FLACS has been a previous year question. What does FLACS stand for? It is femto laser assisted. Since the laser is only assisting your cataract surgery, so not everything is done by the laser. It is going to do capsulorhexis, it is going to give incision, and it is going to do only nuclear fragmentation. So only these three steps are done by femto laser. If we talk about the IOL types, so this is your AC IOL, anterior chamber IOL, that is Kelman multiflex type. Look at the loops. This with two cuts here, this is your iris supported, that is Singh and Wurst lenses. These are your posterior chamber IOL. This is a C loop type. This is a 4 loop type. Just look at the 4 loops of this posterior chamber IOL. If we look at the formula for calculating IOL, that is SRK2, Shah Rukh Khan 2 in a modified version of Shah Rukh Khan. Power is equal to A. A stands for the A constant of the lens, minus 0.9 into K. K stands for the corneal curvature, minus 2.5 into L. L stands for axial length. Then if you look at the complications of cataract surgery, it can be PCR and vitreous loss. PCR is your posterior capsular rupture. So this is how your PCR looks like. Then is corneal decompensation. This occurs when your cataract is hard and chances are more in phacoemulsification than your ECCE and SICS. Next is endophthalmitis. This is your pus in anterior chamber called as hypopyon. Endophthalmitis, what is happening? There is inflammation of the cavities. So signs will be hypopyon, that is pus in the vitreous along with pus in the anterior chamber. Along with that, there is inflammation of the vitreous, which you will call as progressive vitritis. So any patient coming with hypopyon with progressive vitritis occurring after cataract surgery, that is endophthalmitis. Patient will come with pain, redness and photophobia. Management, since it is inflammation that is occurring secondary to the infection, so you have to treat infection by giving intravitreal antibiotics. Since it can even be a fungal infection, so intravitreal antibiotics and antifungals. Then is panophthalmitis. Endophthalmitis means anterior chamber and the vitreous cavity. Panophthalmitis means all the layers of cornea are involved. All the layers of eyeball, sorry. Then is cystoid macular edema. This is a previous year question for you. The cystoid macular edema that is occurring after cataract surgery. This is known as Irvine gas syndrome. This is your cystoid macular edema that is occurring after cataract surgery. Management of any cystoid macular edema is anti-VEGF injections. Since cystoid macular edema is occurring due to increase in VEGF levels. Then you can have posterior capsular opacification. It can be either this type, this is Elschnig pearl, or in the periphery there can be thickening, which you call as ring of Sommering. Rings in the periphery, pearls in the center. Then what is papillae, what is follicle? If you look here, these are what? These are reddish, flat topped lesions. So these are what you call as papillae. These are characteristic of bacterial and allergic conjunctivitis. If you look here, these are white lesions. So these white lesions are what you call as follicles. These are characteristically seen in viral infections and in trachoma. So this is how both of these they look. Bacterial conjunctivitis, most common cause is Staph aureus. If you look at the discharge, I have told you in all types of conjunctivitis you will differentiate it based on the type of discharge. Okay, so if we look at the characteristic of discharge, this is going to be either mucopurulent or purulent. Since it is bacterial, go for antibiotics. Topical systemic antibiotics are indicated whenever the infection is very severe, as in Neisseria gonorrhea and Neisseria meningitidis. If you look at this image, there is skin excoriation here, right? This is skin excoriation at the angles of the eye. These are the angles of the eye. Cause is Moraxella Axenfeld. Management is going to be tetracycline, zinc oxide ointment and lotions. This is your membrane. So it can be membranous conjunctivitis. So what is the most common cause of membranous conjunctivitis? Most common cause, if you talk in children, it is Corynebacterium diphtheriae. If you ask what is the most common cause in adults, it is your Streptococcus hemolyticus. Management, remove the membrane, go for antibiotics. Then this is chlamydia conjunctivitis. What are the things that chlamydia can cause? So chlamydia A, B, BA and C serotypes, they can cause trachoma, and the ones that are D2K, they can cause either adult inclusion conjunctivitis or they can cause either adult inclusion conjunctivitis or ophthalmia neonatorum in children. Now looking at the conjunctival signs, so patient can have either these are called as, these are the follicles I told you, they are common in trachoma, known as boiled sago grains. If you have seen sago grains, they also appear white like this. Then this is Arl's line. What is Arl's line? It is a subconjunctival line of scarring that is seen in patients of trachoma. Then if you talk about the corneal signs, this is your recent July 25 question. These depressed lesions on the limbus, these are known as Herbert's pits. These are again due to scarring. If you see, then scarring is very common in trachoma. Everywhere from conjunctiva to cornea to eyelids, scarring is the key of this disease. Then if you look here, what is this? This is your pannus formation. So in cornea, either you can have Herbert's pits like this on the limbus, or you can have a pannus formation like this. Then chronic infiltration and scarring, I told you scarring is the key. It can lead to tylosis, trichiasis, symplephron and entropion. Then is Fisto classification for trachoma. F is follicular inflammation. I stands for intense inflammation. When you can't see the blood vessels, inflammation is so much. S is for scarring, T is for trichiasis, O is for corneal opacity. If we talk about management, if the prevalence is more than 10%, go for safe strategy. Now what is safe strategy? S is surgery. You do surgery for entropion. A is antibiotics. You give antibiotics for the infection. F is facial cleanliness. E is environmental hygiene. So whenever the prevalence is more than 10%, go for all of these. If it is between 5 to 10%, go for F and E only. If it is less than 5%, then do nothing. If you talk about the treatment of trachoma, treatment is single dose 1 gram azithromycin. If we talk about the blanket therapy of trachoma, it is eye ointment, tetracycline, applied BD, that means twice a day for 5 days per month for 6 months. So in short, in 6 months, in 6 months you have to go give the blanket therapy. In every month you have to give 10 doses. Okay, for consecutive 5 days. Then moving on to viral conjunctivitis, this key feature, if you ask me, it is nothing but your serous discharge. Then what are the types? It can be either acute hemorrhagic, that is seen in enterovirus type 70, or it can be follicular. Follicular, you need to know, it can be either epidemic keratoconjunctivitis caused by adenovirus 8 and 19, or it can be pharyngoconjunctival fever that is caused by adenovirus serotypes 3 and 7. So this is important for your exam. Then if we talk about ophthalmia neonatorum, this is what you call as ophthalmia neonatorum. They say that any discharge that is seen within 1 week of birth, that is when you suspect that okay, there is something, this is what you diagnose as ophthalmia neonatorum. Then discharge can be different types based on the causative organism. So it can be watery in case of chemical, or it can be purulent when your bacteria is infected. Then etiology is based on time frame. Within 2 to 4 hours of birth, it is chemical. Within 48 hours, it is generally going to be Neisseria gonorrhea. Within 5 to 7 days of birth, it is going to be HSV type 2. And more than 7 days, it is going to be chlamydia trachoma. What is the management? Management, it depends on the cause of ophthalmia neonatorum. Then if you talk about allergic conjunctivitis, the other name is, in allergic conjunctivitis there are different types. Most common or the most important that you need to know for your exams is vernal keratoconjunctivitis. This is a repeated previous year question. This is most commonly seen in boys of 5 to 18 years of age. It is commonly a type 1 hypersensitivity reaction more than type 2. Discharge is characteristically ropey or stringy. Conjunctival signs, either you can have papillae, which are characteristically called as cobblestone papillae or the big papillae. Then you have these very big papillae, more than 1 mm papillae, which you call as giant papillae. Or you can have these perilimbal papillae, which you call as Horner's Trantas dots. Yes, Anirudh, it is right. It is an IgE mediated immune reaction, and it involves your muscles. Then corneal signs, if we look, it can be either punctate keratitis. Then there are, see, the papillae are going to cause microabrasion and macroabrasion. So punctate keratitis whenever there are microabrasion, or a big shield ulcer whenever there are macroabrasion. And when on this ulcer there is deposition of exudate, you will call it as vernal corneal plaque. This is your vernal corneal plaque. Or the patient can even have this thing which you call as pseudogerontoxin. Management will be antihistaminics such as olopatadine, or mast cell stabilizers such as sodium chromoglycate. Apart from it, you can go for steroids in severe cases, and sometimes when it is very long, you can even go for immunosuppressants. The common ones that we use are cyclosporin and tacrolimus. Good morning. See, you have missed a few parts. You can go back, you can revise, and from now on you can carry on. So the ones that are commonly used are cyclosporin and tacrolimus. Then if we talk about pterygium, the most important, it is a fleshy fleshy fold of conjunctiva over the cornea. The risk factors include limbal stem cell deficiency, and UV rays and dust exposure. If we talk about the parts of the pterygium, this is the cap, then you have the body, head, then you have the neck is this constricted part, and posterior most you have got the body of pterygium. One thing that is seen in pterygium is your Stocker's line. It is nothing but this line. This is iron deposition ahead of the cap of pterygium, and when this is present, this indicates your pterygium is stationary. It is known to cause with the rule astigmatism. Management involves surgical resection and autologous graft implantation, which is also known as perfect surgery. What is perfect surgery? Perfect surgery is for pterygium extended resection followed by extended conjunctival transplantation. How to prevent drugs recurrence? By using drugs such as mitomycin C and thiotepa. So there has been question on this, there has been question on this. This with the rule astigmatism, this is an expected question. Moving on to diabetic retinopathy, earliest clinical sign is the presence of microaneurysm. Earliest histopathological sign is the loss of pericytes. And if we talk about NPDR, non-proliferative diabetic retinopathy, clinical features include microaneurysm, hemorrhages. Hemorrhages can either be dot blot or flame shaped, or you can have cotton wool spots. Apart from it, you can have venous beadings, edemas. If you talk about proliferative diabetic retinopathy, you can have either neovascularization, that can be either on the disc or anywhere else, which you call as elsewhere, or you can have tractional retinal detachment, or in PDR you can have vitreous hemorrhage. Then if we look at how all these look, these are your hemorrhages. These flame shaped hemorrhages, this is dot blot hemorrhage. This white fluffy dot, yellow white, is what you call as cotton wool spot. This is your fragile thin blood vessels. You will call it as neovascularization. Since this is occurring on the optic disc, so this is neovascularization of optic disc. This is your hemorrhage in the vitreous, known as vitreous hemorrhage. This is your traction bands that are pulling the retina forward, leading to retinal detachment. So this is how they look on fundus photo. Then talking about the classification of diabetes, mild NPDR, you are going to have only microaneurysm. Moderate, you are going to get microaneurysm, along with that cotton wool spots and some hemorrhages. Then severe NPDR, this is a previous year question. What is the criteria for severe NPDR? Remember HVI rule of 4-2-1. That means hemorrhages in 4 quadrants, venous beading in 2 quadrants, and edemas in 1 quadrant. When any of these is present, you will call it as severe NPDR. Proliferative diabetic retinopathy, I have told you, it can be either neovascularization, vitreous hemorrhage, pre-retinal hemorrhage, or even your retinal detachment. So this is important for your exam, since once you have got a question in your exam. Then if you look at clinically CSME is clinically significant macular edema. This is how you look. What are you going to see? You are going to see here these yellow dots that are around the macula known as hard exudates. So in clinically significant macular edema, you are going to see hard exudates that are centered around the macula. So this is what you call as clinically significant macular edema. Now it occurs, why does it occur? This occurs due to the breakdown of blood retinal barrier. Now this breakdown of blood retinal barrier will lead to increase in the VEGF levels. So how will you manage it? Management is very simple. Decrease this by giving anti-VEGF drugs. What are the anti-VEGF drugs? They are ranibizumab, all the zumabs. Then is pegaptinib sodium and another zumab, that is bevacizumab. Okay. Now this is your clinically significant macular edema management. I have already told you. Now moving on to central retinal vein occlusion. Risk factors, remember, hypertension and increasing age. Now very important thing is all the arterial and venous occlusions of retina. Remember this thing, they are sudden and painless in nature. That means patient is going to have sudden and painless loss of vision. If we look at the clinical features is this, what you call as tomato splash fundus. This is a previous year question. Talking about the management again, there is edema in the macular area, so you are going to give anti-VEGF drugs. Talking about the most common complication of CRVO, it is 100 or 90 day glaucoma. This is again a previous year question. Again, this is your previous year question. Central retinal artery occlusion, I told you all the occlusions are sudden painless, characterized by sudden painless loss of vision. Single most important risk factor for CRAO, it is atherosclerosis. Clinical features, if we look like, this is your pale and edematous white retina. If you look here, this is white. Then this is your cherry red spot. Then number 3, this is your cattle tracking of blood. So this is your cattle tracking of blood. Now if you ask me the differential diagnosis of CRAO, again a previous year question. Mnemonic for this is cherry trees never grow tall in sand, mud, grime. Now cherry, C, CRAO, trees, trauma, which is also known as Berlin's edema. So whenever you have a trauma and you get a cherry red spot on the retina, you will call it as Berlin's edema. N is Niemann-Pick. G is Gaucher's disease. T is Tay-Sachs disease. S is Sandhoff disease. M is metachromatic leukodystrophy. G is gangliosidosis. So these are the differential diagnosis of CRAO. Then is management of CRAO. Management, it involves the dislodging of the thrombus. Now this thrombus can be dislodged of thrombus or your embolus. Now how to dislodge this thrombus or the embolus? Either by doing ocular massage, by doing anterior chamber paracentesis, or by giving IV mannitol. What will anterior chamber paracentesis and IV mannitol do? They will lead to sudden decrease in the intraocular pressure, which will automatically dislodge the thrombus. Then apart from these, you can go for inhalation of carbogen mixture. Now this carbogen mixture includes 95% oxygen and 5% CO2. Apart from it, you can give other anti-glaucoma drugs such as acetazolamide or timolol. See, Anirudh, it is not ICP, it is IOP, intraocular pressure. ICP is intracranial pressure. Then Keith Wagner Barker classification for hypertension, again a previous year question. Remember, in grade 1 there is slight narrowing of the blood vessels, and grade 1 there is generalized and slight narrowing of blood vessels. If you move on to grade 2, it is focal narrowing, which is moderate to marked. That means it is more than grade 1. Along with that, the patient is going to have AV nicking, which is characteristic of grade 2 and also known as Salus sign. Then you have grade 3, in which you can have cotton wool spots, hemorrhages. Along with this, what is the patient going to have? In this, the patient is going to have copper wiring of the arterioles. Apart from it, patient can have Guns and Bonnet sign. Then grade 4, patient will have papilledema, that is bilateral optic disc edema, along with silver wiring of arterioles. Yes, Surbi, you are absolutely right. This is what you get. So, previous year question has been on grade 4 of hypertensive retinopathy. So, in that question, there was given that the patient is hypertension, patient is having papilledema, and patient is having hemorrhages, silver wiring, copper wiring. What is the grade? As soon as papilledema comes into picture, your answer changes to grade 4. Then talking about retinitis pigmentosa, what is it? It is nothing but a inherited dystrophy of the rods. So we know that rods are responsible for night vision. Whenever there is dystrophy of rods, what will happen? Patient will have loss of night vision, which you call as nyctalopia or night blindness. Okay. Now inheritance is most commonly In case of cerebral edema, we prefer mannitol to decrease ICP. See, in any edema, be it intracranial or be it intraocular, you will give mannitol, okay, that will decrease the pressure. But in CRAO, we are talking about the eye, we are not talking about the brain. So we are going to give intravenous mannitol. It will cause fluctuation in both intracranial and intraocular pressure, but our motive is not intracranial pressure. Our motive is intraocular pressure. Okay, so I think that clears your query, Anirudh. So if we talk about the most common inheritance in retinitis pigmentosa, it is sporadic. Best prognosis is autosomal dominant and worst is X-linked recessive. It is characterized by this triad. Whenever you see a picture like this, in which you see these bony spicules in the mid periphery, along with that optic disc pallor, and number 3, thread-like arterioles. Whenever you see this triad, that means it is a patient of retinitis pigmentosa. Clinical presentation, I have told you, it is nyctalopia, and what happens over the time when these spicules keep on coming towards the center and towards the periphery, patient will be left with the tunnel vision, or what you call as donut vision. This is the visual field. Everything from here will be gone. This is left. This is your donut or the tunnel vision. Management, nothing. Go for low vision aids. Then moving on to cystoid macular edema. Look at this. It is characterized by fluid accumulation in the inner retinal layers. Why does it occur? I have told you it occurs because of breakdown of blood retinal barrier that leads to the upregulation of VEGF. Causes, very important. Causes include, it can occur in diabetes mellitus when it is known as clinically significant macular edema. It can occur after cataract surgery as a complication where you call it as Irvine gas syndrome. Then it can occur in any venous occlusion such as central retinal vein occlusion, branch retinal vein occlusion. It is common in patients of posterior uveitis and the patients who are taking prostaglandin analogs for glaucoma. OCT appearance will show this. What do you call this as? This is called as honeycomb appearance. This is a previous year question. FFA appearance of cystoid macular edema. This is your flower petal appearance. If we talk about the management, I have told you it is universal. Go for anti-VEGF injections. Then CSR, you see anything like this in OCT. Look here, this is multiple cystic fluid, multiple fluid filled spaces. Okay, this is a well circumscribed dome shaped elevation. You call this as CSR. So it is characterized by separation of neural and sensory retina. Clinical presentation, very important. Right, anti-VEGF drug is ranibizumab, bevacizumab and pegaptinib sodium. Clinical presentation for CSR, it includes a young male with unilateral loss of vision that is sudden and painless. Now risk factors include, yes, a young male who is a smoker, who is type A personality, who has Cushing syndrome, then history of obstructive sleep apnea or common in pregnant females. Clinical presentation, very important whenever you are having metamorphopsia or micropsia, and in this you even see acquired hyperopia. Management will involve just wait and watch for 3 months. Why? Because it is self-limiting. If there is no improvement even after 3 months, then you go for focal laser or you go for photodynamic therapy with verteporfin. Now you know this is the OCT appearance, and if you ask FFA, you can get either ink blot appearance or smokestack appearance. Ink blot appearance is more common, but smokestack appearance, it is more specific of central serous chorioretinopathy. Age-related macular degeneration, other name is it is of two types, dry ARMD and wet ARMD. ARMD is short form for age-related macular degeneration. Dry one, clinical presentation is metamorphopsia. Metamorphopsia means a line that is straight. To a patient of CSR, it will appear wavy like this. Micropsia means object which is of this size. Patient will perceive it as small. That is smaller size is micropsia. And acquired hyperopia. See what happens in CSR. This is the normal person's eyeball. So in CSR, what will happen? Your retina will be elevated. So if we see the axial length of the eyeball will decrease. Since the axial length of the eyeball will decrease, eye of the patient will behave as if that eye has got hypermetropia, and the other name for hypermetropia is hyperopia. So we say this is another clinical presentation is acquired hyperopia. So am I clear, Anirudh? Is it clear? Okay, so dry ARMD, other name is non-neovascular ARMD. Wet ARMD also known as neovascular ARMD. If we see, pathogenesis involves the formation of drusens. These are the drusens, multiple small yellow dots in the area of macula. If we say in wet ARMD, it involves hemorrhage at the macula. If we talk about RPE changes, it is characterized by geographical atrophy in late stage. If we talk about wet ARMD, it is characterized by neovascular membrane. Okay. Then dry ARMD, since there are only drusens, so management is going to be ARMD cocktail. What is it? It is nothing but multivitamins for the eye, vitamin A, vitamin E, vitamin C, zinc, lutein and zeaxanthin. Basically your multivitamins for the eye. Wet ARMD, since there is neovascularization. Neovascularization anywhere in the retina, one management. Go for anti-VEGF drugs. Okay, so this is how you manage ARMD. Dry ARMD and your wet ARMD. I hope I am clear till here. Okay, so retinal detachment, we know retinal detachment, it is the separation of the neural and the sensory retina. So in CSR there was localized separation. This is generalized separation. Types can be rhegmatogenous, tractional, exudative. Rhegmatogenous risk factors include, very important, high myopia, any history of trauma or any snail track or the lattice degeneration. Pathogenesis involves any of these risk factors that is followed by syneresis. Syneresis means vitreous liquefaction. What will it lead to? It will lead to the separation of, suppose a patient is predisposed to any of these risk factors which is associated with liquefaction of vitreous. What will happen? This liquid vitreous will seep inside the retina via the hole or the tear. And what will happen once the liquid seeps inside the retina? It will lead to separation. Symptoms very important: PYQ, floaters, photopsias and amaurosis fugax. Photopsia is also known as flashes of light. This is how your retinal detachment looks like. Again, a previous year question. Then if we talk about tractional retinal detachment, risk factors include diabetic retinopathy and sickle cell anemia. Just learn diabetic retinopathy for now. What will it lead to? It will lead to traction of the retina because of the formation of proliferative bands. Symptoms, again, patient will come with a gradual decrease in vision and it is going to be painless. See, Schaffer's sign is seen in rhegmatogenous RD. What is Schaffer's sign? It is also known as tobacco dust sign. Why does it occur? Suppose this is the area of the tear or the hole. Through that area, retinal pigment cells of the retinal pigment epithelium, what will they do? They will keep on dispersing their pigment into the anterior vitreous. So when this pigment goes and disperses into the anterior vitreous, this is what you call as Schaffer's or tobacco dust sign. Then is exudative RD. Risk factors involve any hypertension or toxemia of pregnancy. What will they lead to? They will lead to the localized separation of the retina. Then what is the sign that is characteristically seen in exudative RD? It is shifting fluid sign. So shifting fluid sign is characteristic of exudative RD and Schaffer's sign is characteristic of rhegmatogenous RD. Then symptoms, exudative RD, again patient is going to come with amaurosis fugax. Management, this is your retina, separated retina. You have to drain this fluid, then provide internal tamponade with either gas or oil and external tamponade by scleral buckle. So basically drain the fluid and just join all the two layers of the retina together. Now talking about retinopathy of prematurity, we know this is the retinopathy that is occurring in premature infants. Now when to screen for a child who is less than 28 weeks and birth weight is less than 2 kgs. What are you going to do? You are going to screen the child at 2 to 3 weeks. You ask me precisely, I'll say 2 weeks. For a child of 34 weeks, you will screen the child at 4 weeks. This 2 to 3 and 4 weeks is the postnatal age. Then for a child who is between 34 to 36 weeks but has a history of either sepsis or nicustae or oxygen supplementation, again you screen the child by 4 weeks. Talking about the zone, if you take the distance between the optic disc and macula to be R and using 2R as the radius, you draw a circle, you get zone 1. Zone 2, you take everything from the nasal retina up to the optic disc to be the radius and you draw a circle. Then is zone 3, it is the remainder temporal crescent. Then is stages of ROP. Stage 1, it is the formation of a demarcation line between the vascular and the avascular retina. Stage 2 is the formation of a ridge. Stage 3 is characterized by formation of ridge along with some extravascular proliferation into the vitreous. Stage 4 is characterized by total retinal detachment, and stage 5 is characterized by total retinal detachment. Then management, if we talk stage 1 to stage 2, you will go for just routine screening. Stage 3, you will go either with the laser, or since there are new vessels, you will go for anti-VEGF. And stage 4 to 5, since there is RD, you have to go for surgery. Retinoblastoma, it is a repeated previous year question. Very important topic for the exam. So, what is it? It is the most common primary intraocular tumor in children. Clinical presentation is somewhere between 18 months to 3 years as leukocoria. This is the most common clinical presentation, followed by squint, followed by glaucoma. This is your leukocoria. It commonly predisposes the patient to pinealoblastoma and osteosarcoma. Then why does it occur? This occurs because of the mutation in RB1 gene that is located on 13q14 chromosome. Talking about diagnosis, histopathological examination stays the gold standard. The characteristic cell you see is a retinoblast. This is nothing but an eosinophilic cell. It can either come as form Homerite pseudorosids or Flexner Wintersiner rosids. What happened in Homerite pseudorosids? If you see, there is an eosinophilic center, but there is no true lumen. These are basically a haphazard type. If you look at these have got a well-defined lumen, and it is surrounded by columnar cells. Okay, so this is Flexner Wintersiner rosids. Now CT scan will show you calcification, another previous year question. MRI will tell you any optic nerve involvement, and aqueous humor will tell you increase in the LDH level. Talking about the management, if it is unilateral, go for enucleation of the eye. If it is bilateral, go for chemotherapy. What are the drugs that you give in chemotherapy? Very important previous year question in the exam. That is VEC chemotherapy. V stands for vincristine, E stands for etoposide, and C refers to carboplatin. You should also know how to identify which one is a pseudorosid and which one is a true rosid formation. Then moving on to visual field effects, repeated topic almost every year in the exam. So just listen to it very carefully. Whenever you are having any damage to the optic nerve here, you are going to get a visual field defect. Then if you are going to have a damage in the optic nerve itself, it will lead to monocular loss of vision. This is the right eye, left eye. Okay, first let me explain you the normal visual pathway. So if we talk about the visual pathway, there are temporal and the nasal fibers of the retina. They will form your optic nerve on both the sides. Then the nasal retinal fibers or the nasal fibers of the optic nerve, they will cross each other at the site of optic chiasma. Okay, beyond the optic chiasma we have got optic tract. So what will the optic tract contain? It will contain ipsilateral temporal and contralateral nasal fibers. They will go up to the lateral geniculate body. From there we are going to have two types of radiation, one that loop around the parietal lobe and the other one that loop around the temporal lobe. They will finally go to your occipital cortex. So let us see the visual field effects. If there is damage at the level of optic nerve, patient is going to get monocular loss of vision. damage at the level of optic chiasma. Remember, optic chiasma is the only lesion that will lead to bitemporal hemianopia. Now let us quickly look, why does bitemporal hemianopia occur? Remember one thing, in visual field defects, if the nasal fibers are damaged, you are going to get temporal visual field defects. If the temporal fibers are damaged, you are going to get nasal visual field defect. So in optic chiasma, both the nasal fibers are gone. So you are going to have both eyes temporal hemianopia. Then if in the optic tract, fibers, what fibers are running in this optic tract? It is going to be ipsilateral temporal and contralateral nasal fibers, right? So for the right eye, your temporal fibers are gone. This is the right eye, this is the left eye. So you are going to get nasal field effect. And in the left eye, nasal fibers are gone, so you are going to get temporal field effect. So this is what you call as contralateral homonymous hemianopia. Now this occurs up to the little geniculate body. Once we move beyond the lateral geniculate body, we have got two types of fibers. Now the fibers that loop around the parietal lobe are known as Bohm's loop. Okay, and since they go superiorly, so they are going to enter into the superior visual cortex. What will it contain? Again, it will contain fibers from the ipsilateral temporal and the contralateral nasal retina. As I told you that visual field defects are opposite to the side or the site where they are affected. So if the superior fibers are affected, what is the patient going to get? Patient is going to get superior fibers are affected, patient is going to get inferior visual field defect. Okay, like this. Let me show you this. This occurs when your parietal lobe fibers are affected. Parietal ones are known as Bohm's loop. Then when your the fibers that loop around the temporal lobe are affected, they are known as Mayer's loop. What will happen? The patient is going to get, since the parietal ones are superior, so inferior field defect. Inferior one is also known as pie in the floor. Since the temporal lobe is located a bit inferiorly, so you will have the superior defect. You will call it as pie in the sky. So pie in the sky is another name of contralateral superior quadrantopia, and pie in the floor is the other name for contralateral inferior quadrantopia. Then suppose your visual cortex is damaged. Then what will happen? You are going to get contralateral homonymous hemianopia again, but macular sparing. Why macular sparing? Because macula is represented at the tip of occipital cortex, and generally any arterial occlusion, the tip of the occipital cortex is spared. So what is the lesion that involves the tip of the occipital cortex? So tip of the occipital cortex is involved in head trauma. So whenever there is head trauma, what is going to happen? There is going to be just contralateral macular hemianopia. Okay. Then if we talk about the causes of bitemporal hemianopia, this is very important. Previous year question also, it is 3PC. So any third ventricular glioma, any pituitary macroadenoma, craniopharyngioma, then any anterior cerebral artery aneurysm or cavernous sinus thrombosis. So this 3PC and AC is the other causes of bitemporal hemianopia. Moving on to light reflex pathway. Light reflex pathway, how does it occur? It occurs along the optic nerve. So once the fibers, they go up to your lateral geniculate body. What happens? From the lateral geniculate body, these fibers go to the pretactal nucleus. From the pretactal nucleus, there are internuncial fibers that supply the Edinger-Westphal nucleus of both the sides. So from the Edinger-Westphal nucleus, it will go up to the motor nuclei of third cranial nerve, and then it will go into the ciliary ganglion, from where you have got short ciliary nerves which will finally go and supply your sphincter pupillae. So what is the normal light reflex? So we say that the light reflex is normal when your pupil constricts. So in any condition when your pupil is not constricting, that means you have an abnormal light reflex. Okay, let us look at the anomalies of pupillary reaction now. Amerotic pupil. Amerotic pupil, it is characterized by ipsilateral direct reflex is gone. Now there are two types of reflex, direct and consensual. Direct reflex is when you are throwing light, suppose in the right eye. The constriction of pupil of this right eye is direct, and simultaneously because of the internuncial fibers that supply the Edinger-Westphal nuclei of both the sides, what will happen? The other eye, the other side pupil will also constrict. Why is it constricting? Because of consensual light reflex. So in amerotic pupil, your ipsilateral direct reflex is gone and your contralateral consensual light reflex is gone. So what is the site of lesion? It is your optic nerve damage. Another thing is RAPD. RAPD is also known as relative afferent pupillary defect, also known as Marcus gun pupil. It is this is a previous year question. How do you diagnose it? It is diagnosed on swinging flashlight test. So if you get an image in which a cardboard is placed here and torchlight is swinging like this, that is, they are testing your RAPD or the Marcus gun pupil. What happens in this? It is characterized by paradoxical dilatation of pupil when the light is shown in the eye. Another is your vernix hemianopic pupil. Now vernix hemianopic pupil, this occurs because of damage to the optic tract. Now what happens in optic tract? Optic tract carries the lesion, carries the fibers of ipsilateral temporal and contralateral nasal retina, right? So in vernix hemianopic pupil, whenever you shine light on either ipsilateral temporal or contralateral nasal retina, there will be no pupillary constriction. Then you have eddy-stonic pupil. It is commonly seen in young females with orthostatic hypotension, absent knee jerks. Light reflex, both direct and indirect in the ipsilateral eye, is gone. Convergence is sluggish, and tonic pupil, it dilates well with 0.125% pilocarpine. Then you have Ergile-Robertson pupil. This is characteristically seen in patients of neurosyphilis. What happens in this? The internuncial fibers are gone. So ARP stands for accommodation reflex present, but if we move PRA, pupillary reflex absent. So this is how it is. Then you have a Hutchinson pupil, which is also known as dilated pupil. So these are the anomalies of pupillary reaction. Then any patient with an optic nerve disease will present with these three characteristics: decrease in the vision, presence of RAPD, and impaired color vision. Color vision is also impaired primarily for red-green colors. So the patient will have red-green color blindness. Very important. In question, any three of these is mentioned, that means they are talking about any disease of the optic nerve. Then optic neuritis, most common cause in children is your viral infections, but most common cause in adults is your multiple sclerosis. Then it is characterized by sudden marked diminution of vision unilaterally. It is generally painless except in your retrobulbar neuritis. Types can be either this papillitis. Papillitis is when only your optic nerve head is involved, or neuroretinitis when your retina is also involved, or retrobulbar neuritis. Retrobulbar means behind the optic nerve. Fundus, it can be either in papillitis, it is going to be edematous and hyperemic optic disc. So if you are given a picture like this, that means they are talking about papillitis or optic neuritis. Then if you talk about retrobulbar neuritis, since this part is involved, the fundus will be absolutely normal. If you talk about the scotomas, it is characteristically central or the centrocecal. Management will involve first confirmation. Confirmation will be done by MRI brain with orbits. Once you confirm it, then you go with IV steroids. Primarily we go with methylprednisolone for 3 days, which is then followed by oral steroids for 11 days. So that means a total course of 14 days. If you look at this optic nerve, this is normal. Exactly, patient and doctor, they both see nothing. That is characteristic of retrobulbar neuritis. This is your image of hyperemic optic disc. Okay. Then papilledema. Papilledema is characterized by bilateral optic disc edema that is occurring secondary to raised intracranial pressure. Now, fundus findings are important. Let us quickly see. This is the optic disc is going to be edematous. There are going to be hemorrhages on the optic disc. Then there will be around the optic disc, because of edema, there will be pressure on the retina and there are going to be Patton's lines. What are Patton's lines? These are your peripapillary lines of retinal wrinkling. Then you can, in chronic cases, you can have these. This is what you call as champagne cork appearance. Okay, this is champagne cork appearance. Looking at another entity, that is optic atrophy. So it can be primary, secondary or consecutive. Primary, it is occurring when your retinal ganglion cells from the retina to the lateral geniculate body, they are affected. So what happens? There is optic disc pallor. If you look at this optic disc and you look here, so this is normally red and this is central white. Okay, this is a case of optic atrophy. So in primary optic atrophy, there is no disc swelling and the disc is chalky white with well defined margins. Causes include optic neuritis, trauma and hereditary optic neuropathy. Secondary is the one that is occurring after any disc swelling. Suppose the patient had optic neuritis or papilledema. Whenever you have long-standing, chronic, untreated optic neuritis or papilledema, then your optic nerve will be permanently damaged. Okay, that is what you call as secondary optic atrophy. Then causes include papillitis, papilledema, and anterior ischemic optic atrophy. Then consecutive optic atrophy is the one that occurs because of the disease of the inner retina. Okay, what is happening in consecutive optic atrophy? There is damage to the blood supply of the retina. Okay, and the optic disc. So whenever there is any disease that is damaging the blood supply of optic disc, the atrophy that is occurring is what you call as consecutive optic atrophy. It is commonly seen in conditions such as CRAO, CRVO, retinitis pigmentosa, and healed vasculitis. See, Surbhi, sixth nerve palsy is not seen in papilledema per se, but it is it is a coincidental finding. Why? See, in papilledema, why is papilledema occurring? It is occurring because of increased intracranial pressure, right? And we know that whenever the intracranial pressure is increased, sixth nerve has got the longest course. You also know that. So whenever your intracranial pressure is increased, it is somehow going to compress your sixth cranial nerve somewhere or the other. So if you say that sixth cranial nerve palsy is always occurring with papilledema, it is not true. It will occur only if the intracranial pressure has risen so much that it is compressing the sixth nerve. So yes, they are seen together, but they are not seen always because they both have a different pathology. Pathology is same, but if the optic nerve is getting affected, you are going to get papilledema, and if your sixth nerve is getting compressed, then only you are going to get the palsy. If that is not compressed, you are not going to get. So sometimes we get papilledema, but we don't get sixth nerve palsy. Sometimes we get sixth nerve palsy, we don't get papilledema, and sometimes we get it together. Then moving on to oculosympathetic pathway, which is also known as which is actually the sympathetic pathway to the eye. What does it involve? It involves your hypothalamus to your ciliospinal center, then from your ciliospinal center to your superior cervical ganglion. So this pathway is your oculosympathetic pathway, and it is responsible for carrying the sympathetic fibers to your eye. Now any damage to this pathway will lead to what you call as Horner syndrome. Why? Because this sympathetic pathway will supply your sweat glands of the face, dilator muscles of the eye, smooth muscle of the eyelid, and the sweat glands of the forehead. So what is Horner syndrome? It is characterized by ptosis, meiosis, anhidrosis, and enophthalmos. Enophthalmos means your eyeball will appear to go inside. Basically what happens is there is decreased in the palpebral aperture, which is occurring due to ptosis. So it will appear as if the eyeball has moved inside. So this, what you call it as, you will call it as apparent anophthalmos. It will appear as if the patient has anophthalmos. So this is your Horner syndrome. Again, a previous year question. Now moving on to the actions of extraocular muscles. Remember 2-3 points. RAD and SYN. Okay, RAD is recti are adductors. SYN is superiors are intorters. Another thing is obliques act opposite to their names. Now, very important is, what does all this mean? Superior rectus, if you take the example of superior rectus, so it is superior, it will cause elevation, primary action. Recti, adductor, superior, intortor. Moving on to superior oblique, it will act opposite to its name. So since it is superior oblique, it will cause depression. Recti will cause adduction, so oblique will cause abduction. Then since it is a superior, it will cause intorsion. So this is how you tell. Lateral rectus and medial rectus have got only one function. Lateral rectus will cause abduction, medial will cause adduction. So these are important. Another previous year question is this. See, your recti and oblique, they originate from your apex of the orbit, but they insert onto the sclera. Now, very important is, if we talk about the recti originate from the annulus of Zinn and they insert onto the sclera anterior to the equator of the eyeball. Now, what is the distance of this insertion from the limbus? This is a previous year question. Distance of insertion from the limbus is MILS. Mnemonic is mother-in-laws. So medial rectus will be inserted at a distance of 5.5 mm from the limbus. Inferior rectus at a distance of 6.5 mm. Lateral rectus 6.9 mm. And superior rectus 7.7 mm. So this is the distance. Now laws governing the ocular motility. Yoke muscle, let us discuss the yoke muscle first. What are yoke muscles? We know these are contralateral synergies. So these are the muscles of the two eyes that act together to cause same function. Okay. Now since these are contralateral synergies, so that means these are the muscles of two eyes. So one eye is going to have one muscle, other is going to have another muscle. Suppose we say dextroversion. So in my dextroversion, right lateral rectus and left medial rectus, these are my yoke muscles. Now how to tell yoke muscles? For medial and lateral rectus it is easy, but how for recti, superior and inferior recti and oblique? So if we talk about right superior rectus, change everything. Right to left, superior to inferior, recti to oblique. So the yoke muscle of right superior rectus is going to be left inferior oblique. If you talk about left superior oblique, it is going to be right inferior rectus. So change everything, recti to oblique, superior to inferior and right to left. Now Hering's law of equal innervation, this is the law for the yoke muscle. This law says that in conjugate movements of the two eyes, there is equal amount of nerve supply to the yoke muscles of two eyes. So suppose I am looking towards my right. In my right eye movement of my dextroversion, my right lateral rectus and my left medial rectus will get equal supply. That is your Hering's law. Now, if we move on to binocular single vision, we have got 3 grades of binocular single vision. The mnemonic for that is MFS. M is simultaneous macular perception. F is fusion and S is stereopsis. What happens in simultaneous macular perception? If we are giving 2 different images to 2 different eyes, the ability of the 2 eyes or the brain to fuse it as one. Suppose we have given cage to right eye, bird to left eye. Ability of the brain to fuse it as bird in the cage is your simultaneous macular perception. Then in fusion, if you get two incomplete images which are identical, that is fusion. If the brain is able to fuse it into one, that is fusion. And in stereopsis, what happens is, when you have got two images, you are seeing it from two different angles. Ability of the brain to create a 3D image is your stereopsis, in which you get the actual depth perception. Then anomalies of binocular single vision. Amblyopia is a repeated PYQ that has been asked in your exams. So amblyopia is what? It is temporary cortical inhibition of impulses from one eye. Let us see how the questions in the exam come from amblyopia. If we talk about amblyopia, there is your fundus will be normal. Okay. When does amblyopia occur? When the power difference between the two eyes is more than 2.5 diopters. And if we talk about Snellen's chart, there has to be a difference of at least 2 lines on the Snellen's chart. Whenever in question you are given any of these, that means they are talking about amblyopia. Now talking about another two things that are seen is neutral density filter test and crowding phenomena. So what happens is, whenever in a patient of amblyopia, you keep on increasing the power of this neutral density filter, what will happen? So whenever you keep on increasing the power of neutral density filter in a patient of amblyopia, then amblyopia will improve. Okay, so there will be improvement in vision. So whenever this thing occurs, that means it is a case of amblyopia. Another thing is crowding phenomena. Suppose 6 by 24th line on Snellen chart is show these 4 letters. We ask the patient to read. So a patient who is amblyopic will not be able to read it as properly as a normal patient. But if we give only a single optotype to the patient, then the patient can read comfortably. This is what you call as crowding phenomena. That means when you give multiple optotypes, patient is not able to read. But if you give a single optotype for the same line, the patient will be able to read better. Now what is the management? Management is patching. So which eye will you patch? Very important. It involves patching or the occlusion therapy of normal eye. Why? So that the lazy eye takes up the function that the normal eye is supposed to do. Then talking about squint. Squint can be either a true deviation or a apparent deviation. Apparent deviation is known as pseudostrabismus, and it is seen in cases of hypertelorism or in cases of broad nasal bridge. True deviation can be either heterotropia or heterophoria. Tropia is your manifest squint. Manifest squint is the one that you can see with the naked eye. Heterophoria is also known as latent squint, that you can see only on cover uncover test. Then manifest squint can be comitant squint or incomitant. Incomitant will include paralytic squint and restrictive squint. In paralytic squint, secondary deviation is more than primary deviation. Secondary deviation is the deviation of the normal eye under cover. So what happens is, suppose the right eye is esotropic. So right lateral rectus is paralytic. paralyzed. You close the normal eye. What will the brain do? Brain will try to focus with the paralyzed eye. So how will the brain try to focus? By increasing the nerve supply. So when the nerve supply to this eye will increase, automatically according to Hering's law, the nerve supply to this eye will also increase. But this eye is already covered. So when you try to move it, remove the cover, there will be a sudden corrective movement. Okay. So that tells you that the normal eye under the covered has also deviated. Then is restrictive squint. Restrictive squint, just remember one thing. How will you differentiate between incomitant squint types, between the paralytic and restrictive squint? By doing forced duction test. What is forced duction test? Suppose this is the eyeball of the patient. What will you do? You will take the forceps and try to move it like this. If you feel any resistance is positive, that means it is a case of restrictive squint. If there is no resistance, that means if it is forced duction test negative and it is a case of paralytic squint. Now, esotropia is when your eyeball turns inwards. Accommodative esotropia is the most common type of squint. Exotropia, eyeball will turn outward. Hypotropia, downward. Hypertropia, upward. Heterotropia is manifest squint. Heterophoria is latent squint. Secondary deviation more than primary is paralytic squint. Forced duction test is going to be negative, and primary is equal to secondary deviation in cases of restrictive squint, in which you have forced duction test positive. In cyclotropia, that means the superior 12 o'clock pole of the eye has moved inwards, and excyclotropia means outwards. These are to be done on double Maddox rod test. Then moving on to the test for squint. Firstly, we have to check the ocular movement in all directions of gaze. You have to calculate any refractive error. Why? You will see that whenever the patient is having hypermetropia, whenever you ask the patient of uncorrected hypermetropia child to look at near, what will happen? The child will exert more accommodation. So what will happen? The eyeball will move inwards. So there will be more esotropia. Okay. So you can say that esotropia is seen in hypermetropia. Basically in uncorrected hypermetropia. Then you have to measure the fusional vergence. Fusional vergence is the disjocate movement of the two eyes. Basically, so that the eyes, they look straight forward, or you can say that is the extra power that is needed to prevent esophoria. Then you have to measure ocular deviation. You can either do it via Hirschberg's test. What you do in Hirschberg's test is you will project the torch of light like this into the patient's eye, and you will look at the corneal reflex. So ideally the corneal reflex should be in the center in both eyes, but when the eyeball is deviated outward or inward, there will be deviation of the corneal reflex. So this is a corneal reflex test. Then this is your cover uncover test. What is it used to look for? This is used to look for phorias, and this is your previous year question. Okay, which is also known as latent squint. I think this has been asked in January 2025. Another test is your Maddox rod test. What is Maddox rod? This is your Maddox rod. So if Maddox rod will tell you whether the patient is having a cross diplopia or an uncrossed diplopia, right? So in which condition do we see cross diplopia? Draw a cross like this. It is seen in exotropia. And if you talk about uncrossed diplopia, this is seen in esotropia. Then you can do prism bar cover test. What is prism bar cover test? This is your prism bar cover test. This is your prism and this is your cover test that is being performed. So what are you going to do? You are going to keep the prism of increasing frequency on the patient's eye and do cover uncover test. Okay, what will it tell? So the point or the prism diopter at which there is no deviation on cover uncover test. That is your angle of squint. Another thing what you can do is Hess charting or Lee screening. It will tell you the amount of diplopia. Test for sensory anomalies, you can do either a Worth 4-dot test or a Bagolini's striated glass test. Let us see Worth 4-dot test. This is your Worth 4-dot test. What are you doing in this? You are going to make the patient wear red-green glasses and look inside the torch of light. Principle of this is dissociation of the two eyes. Whenever in squint they ask you the principle of any test, that is going to be dissociation of two eyes. Very important. So if you look at the interpretation, a normal person should see one red dot, one yellow dot and two green dots. So this is a person who is normal. Person who sees 3 green, 2 red dots will have diplopia. Person who sees only 3 green dots will have right eye suppression. Person who will see 2 red dots will have a left eye suppression. So this is how you interpret. English please. Okay, I'll do it that way. If you look at esotropia, eso means eyeball has turned inwards. So this is what? Once this eye is fixing, after some time, this eye will fix and this eye will be esotropic. So this is what you call as alternating fixation in primary gaze. If you look at the eyes of this child, so this eye will see, since this eye is esotropic, it will see this nasal field. This eye will see this visual field. So this is how they'll see the visual fields. What do you call this as? You call this as cross fixation. Since they are seeing the lateral gazes, so you will call it as cross fixation in lateral gaze. Now moving on to cranial nerve palsies, a high yielding topic for the exam. We know if we talk about the nerve supply, it is SO4 LR6, right? And rest all the cranial nerves are supplied by your, rest all the extraocular muscles are supplied by your third cranial nerve, right? So what are the muscles that are supplied by your third cranial nerve? It is levator palpebrae superioris, superior rectus, inferior oblique, medial rectus, and sphincter pupillae and your ciliary muscles also. If you remember the pathway we had studied. So we know that LPS will elevate the eyelid. So if your third cranial nerve is paralyzed, patient is going to have ptosis. Right? Superior rectus, inferior oblique, they will elevate the eyelid. Once they are gone, patient will have a hypotropia. Medial rectus, it will cause adduction. Since it is gone, patient is going to have exotropia. Sphincter pupillae, it will lead to meiosis. It is gone, patient, it will lead to mydriasis. Ciliary muscle, we know it is responsible for causing accommodation. So once the nerve supply is gone, it will lead to loss of accommodation. So can I say in a patient of third cranial nerve palsy, eyeball will be down and out. So down and out eyeball along with the ptosis, along with mydriasis, loss of accommodation, that points towards third cranial nerve palsy. Since the eye is exotropic, so on Maddox rod test, patient is going to have a crossed diplopia. Looking at the management, we are just going to wait and watch because the third cranial nerve will regenerate via its neurolemma. Talking about fourth cranial nerve, that is trochlear, it will supply your superior oblique muscles, which is responsible for intorsion, depression and abduction. Now, when the muscle is paralyzed, what will happen? It will lead to excyclotropia, hypertropia and this hypertropia will increase on adduction, or you can say opposite side gaze. So what are the compensatory measures? Compensatory will be, since the eyeball is hypertrophic, patient will have a chin lift so that patient can get patient will have a chin depression so that patient will get a clear view. Apart from it, since there is increase in hypertropia on adduction, so patient will have a contralateral head tilt. Your eye is exotropic, right? Excyclotropic, like this. So whenever you do a contralateral head tilt, eyeball will move a bit like this. So the patient will not have diplopia. So this is going to be the compensatory measure. Another thing is, how will you diagnose it? By doing Park's 3-step test. Sixth cranial nerve will supply your lateral rectus, which is responsible for abduction. So whenever it is paralyzed, it will lead to esotropia. We know that esotropia on Maddox rod will present as uncrossed diplopia. So this is another important slide for your exam. Now moving on to myasthenia gravis. This has been a repeated PYQ. So what happens in myasthenia gravis? There is a defective function of the extraocular muscles. So what is the patient going to get? Bilateral ptosis that will worsen at the end of the day. Why will it worsen? Because of decrease in the acetylcholine levels. Because of this, patient is going to get diplopia, and it is characterized by Kogan lid twitch sign. What happens in this? Suppose you ask the patient of ocular myasthenia to look upward. So the eyelid that has been downward, it will go sudden upward, then come down. So there will be a twitch in the lid. Why will it occur? This is characteristic of ocular myasthenia. Okay. So there is sudden upshoot of the lid, and then there is a drooping of the lid. So this is your Kogan lid twitch sign. This is the ptotic eyelid before your adrophonium test. This is after. There is improvement in ptosis. Diagnosis can be done via tensilon or adrophonium test. So what are you doing in this? You are injecting 0.2 milligram IV of adrophonia. What will it do? It will decrease the level of acetylcholinesterase. So what will happen? It will increase your acetylcholine levels. Okay. Another is ice pack test. What happens in ice pack test? If we keep the ice pack on the patient's eye for 5 to 10 minutes, there will be cooling, and it is said that cooling increases the level of acetylcholine, thereby leading to improvement in ptosis. So any ptosis increasing by end of day with diplopia and improvement in tensilon test or ice pack test, that is a case of ocular myasthenia gravis. Moving on to tear film, we have got three parts of tear film. Mnemonic is MAL, MAL. M stands for the mucinous layer, which is secreted by the goblet cells of the conjunctiva. A stands for the aqueous part, L stands for the lipid part. Aqueous is secreted by your lacrimal gland, and the lipid part is secreted by your meibomian gland. If you talk about the tear reflex, then afferents go via your fifth cranial nerve, specifically the nasociliary nerve, and your efferent will via your parasympathetic supply to the lacrimal gland. Talking about tear film function test, again it is a previous year question that has been repeatedly asked. So you look for, this is what you call as Schirmer's test. So what are you doing in this? In this you are placing two strips here on the eyelid, and you look for the amount of wetting that has occurred in 5 minutes. So normally this wetting has to be more than 15 mm on this strip. That is normal. So anything that is less than 15 mm is suggestive of dry eye. This is your tear film breakup test. How do we do it? We do it using your fluorescent stain, and you visualize it under cobalt blue filter. Remember one thing, fluorescent stain under cobalt blue filter. How will it look like? It will look like green. This is brilliant green. So what happens is, you stain the tear film with a fluorescent stain and you look for the appearance of first dark spot. So where will the dark spot appear? It will appear at the side where the tear film has broken. Okay. So you look for the appearance of first dark spot, and that is the site of breaking of tear film. Normally it is more than 10 seconds. Another thing you can do is rose bengal stain. This is your rose bengal stain. Then moving on to regurgitation test. This is your regurgitation test and lacrimal syringing test. This is your lacrimal syringing. If you look at the interpretations of lacrimal syringing, these are your upper and lower vertical canaliculi. These are your upper and lower horizontal canaliculi. Then this is your common canaliculus. This opens into the lacrimal sac. Then you have nasolacrimal duct that opens via the valve of Forstner into the inferior meatus of the nose. So this is your normal lacrimal drainage system. If you talk about the lacrimal syringing and its interpretations, here we have got superior and inferior puncta. Okay, so whenever the fluid is coming out through the same puncta, what does that mean? That means same puncta regurgitation, that is suggestive of your horizontal or vertical canalicular obstruction. If the fluid is going and it is coming out through the opposite puncta, that means there is some obstruction at the level of common canaliculus. If it is coming through the opposite puncta, that means there is some obstruction at the level of common canaliculus. And what is a normal lacrimal syringing test? Normal is when the patient feels fluid in the throat. So when everything is patent, what will happen? The fluid that you are giving through syringing, patient will feel it. It will go into the nose, and via the nose it will go into the throat. This is syringing. This thing is what you call as lacrimal probing. Now, congenital dacryocystitis, it is because of the membranous occlusion at the valve of Forstner, or because of congenital nasolacrimal duct obstruction. In this, regurgitation test is going to be positive. Management will involve Krigler massage. So, Krigler massage is generally done up to 1 year of age. Then, between 1 to 4 years of age, you do lacrimal syringing and nasolacrimal duct probing. So this is how they are doing the probing. You insert a probe and you look for two things. You can either have a soft stop or a hard stop. Soft stop indicates there is obstruction at the level of common canaliculus. Hard stop, it indicates that the obstruction is at the level of lacrimal sac or the nasolacrimal duct. So, how will you manage when you have a soft stop? Another PYQ, you will go for conjunctival DCR. Or if it is at the level of lacrimal sac or nasolacrimal duct, you can go either for external DCR or you can go for endonasal DCR. But before this, remember one thing, that up to 1 year you go with Krigler massage, 1 to 4 years you go with lacrimal syringing and nasolacrimal duct probing. DCR is done only after 4 years, not before that. Before that, you go for multiple trials of syringing and probing. Why? Because if it is done less than 4 years, then there are high chances of surgery failure. Okay, that is why it is contraindicated in children less than 4 years. Talking about acute dacryocystitis, you can have the stage of cellulitis, which is treated via hot compression and antibiotics. If there is abscess, you have to drain. Basically, IND, incision and drainage of the abscess, is done again along with the antibiotics. And if there is fistula formation, okay, fistula formation, you have to go for fistulectomy followed by DCR. As I told, in acute inflammation, first line will be antibiotics. Once it turns into chronic means fistula is formed, then you have to go for DCR or DCT. When do you do DCT? DCT is generally done in patients of more than 80 years or when prior DCR has failed. Talking about superior orbital fissure now. Superior orbital fissure, what are the structures that pass through the superiorly through and inferior to the annulus of Zinn via the superior orbital fissure? So superior orbital fissure is just a bony defect in the bones, sphenoid bones. So since this is a defect, so around the defect you have that annulus of Zinn. This is your annulus of Zinn. What will it do? It will divide the defect into 3 parts. Superior part, middle part and the inferior part, right? Now, if we talk about the structures that pass superiorly through and inferior to the annulus of Zinn, then superior, learn one mnemonic, it is liver function test, lacrimal nerve, frontal nerve and the trochlear nerve, okay, and then obviously the superior branch of ophthalmic vein. If we talk about the structures that pass through, that is going to be your third cranial nerve, superior division and your inferior division. Along with that, your nasociliary nerve and the abducens nerve. If we talk inferiorly, nothing, only the inferior ophthalmic vein. So no cranial nerve passes inferiorly. Now, what is superior orbital fissure syndrome? What happens is, since it is present at the back of the eye, and I told you it is a bony defect in the sphenoid bone. So what will the patient have? Patient will have retroorbital pain, ipsilateral ophthalmoplegia. Ipsilateral, since it is here this nerves that are supplying this eye, only they will emerge, right? So it will be ipsilateral and ophthalmoplegia. Ophthalmoplegia means there is paralysis of the muscle supplying the eyeball. So what are the paralysis of the nerves? So what are these nerves? 3, 4 and 6. Third cranial nerve, fourth cranial nerve and sixth. They are all gone. Okay. So this is superior orbital fissure syndrome characterized by retroorbital pain and ipsilateral ophthalmoplegia with ptosis. Why does ptosis occur? Because of the hampering of the nerve supply of LPS, which is normally occurring via your oculomotor nerve. If you talk about orbital apex syndrome, so at the apex of the orbit, apart from these cranial nerves, your second cranial nerve is also coming, right? So since second cranial nerve is getting affected, patient is going to get unilateral vision loss, and ophthalmoplegia, it will be concurrent. That means all the 3 cranial nerves, 3, 4 and 6, they are involved together. Chemosis and proptosis won't be there. Onset is gradual, and the most common cause of this is your Tolosa-Hunt syndrome. Now what is Tolosa-Hunt syndrome? It is nothing but the chronic granulomatous inflammation, right? So this chronic inflammation will lead to orbital apex syndrome. If we have cavernous sinus thrombosis, we know through the cavernous sinus, 3rd, 4th, 6th and V1 and V2 cranial nerve pass. There is no involvement of second cranial nerve. So, vision loss will be absent. We know cavernous sinus thrombosis always starts unilaterally and then involves the other side also. Talking about ophthalmoplegia, in cavernous sinus thrombosis, 6th cranial nerve is the earliest to get affected. Surbi, did you get this? What you were telling me, you were not telling me directly for papilledema, it was for cavernous sinus thrombosis. Why is the earliest, 6th nerve is earliest? Because we know that 6th cranial nerve, it passes through the body of cavernous sinus. Am I clear, Surbi? Are you there? Okay, so if we talk about chemosis and proptosis, yes, it is there in cavernous sinus thrombosis, and cavernous sinus thrombosis is sudden in onset. Now talking about proptosis, proptosis is the protrusion of eyeball that is more than 21 mm beyond the orbital rim. So, if you calculate the distance here from the margin of orbit up to the apex of cornea, if this distance is more than 21 mm, you will call it as proptosis, and it is measured via Hertel's X ophthalmometer, which is shown here. Most common cause in adults is Graves' disease. Now, exam oriented MCQs. What is the cause of pulsatile proptosis? It is keratico-cavernous fistula. What is the condition in which proptosis increases on bending of valsalva? It is orbital varices. That proptosis that increases on crying or straining, that is causes encephalocele in infants or capillary hemangioma in children. Proptosis that is increasing with upper respiratory tract infection, that is your orbital lymphangioma. Looking at the signs in thyroid ophthalmopathy, most important is your lid retraction. So, what do you call this as? Lid retraction in primary gaze, it is your Dalrymple sign. Von Graffe is lid lag in down gaze. Stellwag is decreased frequency of blinking. Cockers is staring appearance. Enroth is puffy swelling of the eyelids, and Gifford is the difficulty eversion of upper eyelid. Next is blowout fracture of orbit. Another repeated previous year question for your exams. What is the pathogenesis? Why does it occur? This occurs due to compression decompression injury of the orbit. Site is at the site of weakest wall, so it is going to be floor of the orbit that is getting affected. So if you look here, this is your teardrop sign that you see characteristically in blowout fracture of the orbit. Clinical features: patient is going to get ecchymosis, edema, emphysema, diplopia, anesthesia over the cheek because of the involvement of infraorbital nerve, and N-ophthalmos. When will you treat it? When the patient will have diplopia or large herniation of contents or the incarceration of orbital tissues, or when the N-ophthalmos is more than 3 mm. Then you will go for the surgery. But otherwise, normally there is no treatment. You leave it as such. Talking about preseptal and orbital cellulitis, this is how preseptal cellulitis will look and this is how orbital cellulitis will look. So, both preseptal and orbital cellulitis, they both start with the infection, most common being dental caries or the upper respiratory tract infection. In preseptal cellulitis, there is only swelling of the eyelids. Is it blank for everybody? In preseptal cellulitis, is it blank for everybody? Okay, let me just connect with the team. Okay, so is it visible? Is the screen fine now? Is the screen fine for everybody? Okay, great. So in preseptal cellulitis, you are just going to have swelling of the eyelids. In orbital cellulitis, apart from swelling, there will be decrease in the extraocular motility, and there will be conjunctival chemosis, and pupil will be non-reactive. Okay, so if we talk about the complication of preseptal cellulitis, if it is not treated on time, it can lead to orbital cellulitis. And orbital cellulitis, if it is not treated on time, it can lead to cavernous sinus thrombosis. If we talk about the management of preseptal cellulitis is nothing but oral antibiotics. For orbital cellulitis is immediate hospitalization with the IV antibiotics. Orbital tumors, most common intraorbital malignancy in adults is cavernous hemangioma. In children, it's rhabdomyosarcoma. In adults, it is malignant melanoma. Most common intraocular malignancy in children is retinoblastoma. If we talk about enucleation, only the optic nerve stump along with the extraocular muscles, they are left behind. So indication is painful blind eye, intraocular malignancy such as retinoblastoma, and if the patient is having risk of sympathetic ophthalmitis. Evisceration, sclera, extraocular muscles and your optic nerve, they are all left behind. So indication is panophthalmitis and expulsive suprachoroidal hemorrhage. Exenteration, what is happening is you are removing everything and you are eventually suturing the lids. You are even removing the periosteum. So indication include rhabdomyosarcoma and mucormycosis. What are the images? This is your D-shaped pupil and this is known as iridodialysis, separation of iris from its root. This is hyphema. This is again hyphema, that is blood in anterior chamber. This is what you call as Berlin's edema. You can see a cherry red spot here. This is occurring after trauma. This is your retinal tear that is occurring after trauma, causing retinal detachment. This is your choroidal rupture. This is a bucket handle tear. Okay. This is your osseous ring, and this is your star-shaped cataract or the roseate cataract. Then congenital glaucoma. If we talk about the triad, patients of congenital glaucoma are below poverty line. Blepharospasm, photophobia, and lacrimation. Clinical examination, there will be corneal enlargement like this, which you call as buphthalmos. There will be horizontal breaks in the Descemet's membrane, which you call as habstri. There will be deep anterior chamber, axial myopia, iridodonesis, and optic cupping. So this optic cupping is reversible up to 2 years of age. So if you correct the intraocular pressure up to 2 years of age, then this optic cupping will be reversible. Management is you have to examine the child under anesthesia. Which drug is contraindicated? Alpha 2 agonists such as brimonidine and apraclonidine. Why are they contraindicated? Because they lead to CNS depression in children. If we talk about the surgical management, if the cornea is clear, then you go for goniotomy. If the cornea is hazy, then you go for trabeculectomy or trabeculotomy. Trabeculectomy is the surgery of choice. Clinical examination, this is your Schwartz tonometer, this or indentation tonometer. This is your Goldman applanation tonometer, which is of applanation type based on Imbert fixed law, which says that intraocular pressure is equal to contact force per unit area. What is the end point of IOP? In cases of Goldman applanation tonometer, it is the point at which the inner circles of the two semicircles, these inner circles of the two semicircles, they meet. So this is the point at which we say, okay, the marking corresponding to this will tell the intraocular pressure. Then is gonioscopy principle. It is based on total internal reflection of light. If we talk at the angle structures, it is STSCR. S stands for Schwalbe's line, T trabecular meshwork, scleral spur, ciliary body band, and R is the root of iris. Now moving on to direct goniolens, indirect. Direct mnemonic is DKR. Direct is Copies and Richardson. These are the examples or the names. Indirect is PIGS, PIGZ. P is Posner's, then is Goldman's, and Z is Zeiss. So these are the names of the direct and indirect goniolens. Optic nerve head changes, if we look, most important is increase in the vertical cup is to disc ratio. This is there. So when this ratio is more than 0.5, this, if you look here, that is when you call as glaucoma. This is your splinter hemorrhage. Just splinter hemorrhage is what? It is the hemorrhage at the optic disc. These are the dots, Le minor dot sign. This is bayoneting. What is bayoneting? It is double angulation of the blood vessels. If you see, there is double angulation of the blood vessels. So bayoneting is double angulation of blood vessel. This is your beta zone of peripapillary atrophy. This is your bearing of circumlinear blood vessels. This is again your cupping. Then if you move on to the visual field defects, mnemonic is in children BP should be doubly checked and tested. I see isopter contraction, B is bearing of blind spot, S is P is paracentral scotoma, S is sedal scotoma, B is the germs or the arcuate scotoma, W is double arcuate scotoma. Then you have, after this you have Roni central nasal step. C stands for central vision and T is the temporal island of vision. Which is the last visual field to go? That is temporal field. You remember this mnemonic, you will know the sequence. So this is the mnemonic for the sequence of visual field defects that you see in glaucoma. Now talking about the anti-glaucoma drugs. So there are drugs that decrease the aqueous production or the ones that increase the either trabecular outflow or the UV scleral outflow. So if we talk about decreasing in production, we have the beta blockers. All the LOL are beta blockers. Then is alpha 2 agonists, that are apraclonidine and brimonidine. Carbonic anhydrase inhibitors are all the mides, acetazolamide, brinzolamide, dorzolamide. The ones that increase the trabecular flow are either cholinomimetic, that is pilocarpine, or the Rho kinase inhibitor, that is nitarsudil. The drugs that increase the UV scleral outflow are your prostaglandin alpha 2 analogs, that is all the prosts. Now, what is the drug of choice for primary open angle glaucoma patients? It is your prostaglandin analogs. What is the second drug of choice for open angle glaucoma? It is your beta blockers. Now, what is primary angle closure glaucoma? This is when your angle is open. This is open angle. Angle closure, what is happening? Anterior chamber angle that is formed by STSR structures, that is closed. Risk factors include a female, high hypermetrope and aggravation in dim light. So, what is the typical history given by the patient? Patient gives a history that whenever she goes to the cinemas or in a dark room, then patient starts to develop severe periorbital pain, nausea, vomiting, redness, colored halos around the light. So what happens is whenever the patient goes to cinema or dark room, there is mydriasis or there is dilatation of pupil. What will it lead to? It will lead to further closure of anterior chamber angle. Now moving on to two important signs. One is eclipse sign. Eclipse sign is what? It is shadow over the nasal iris. When you show light from here, what will happen? Since the angle is shallow, there will be a shadow over the nasal iris. Then is Vogt stride. This is your July 2025 question. It is characterized by pig. P is fixed mid-dilated pupil, patches of iris atrophy and glaucom flecken. What happens is because of angle closure, everywhere there is ischemia. So there will be corneal haze, there will be fixed mid-dilated pupil because of decrease in the blood supply of the sphincter pupillae. Then there will be patches of iris atrophy and there will be glaucom flaken. What is glaucom flaken? It is the cataract that is occurring because of angle closure, repeated attacks of angle closure. If you ask about the management, first line drug is going to be IV hyperosmotic agents. What is it? IV hyperosmotic agents include drugs such as mannitol or acetazolamide. That is given orally. If you ask a drug of choice, that is pilocarpine. This is a previous year question image that was given to you in question and the diagnosis was asked. If you see the pupil is fixed mid-dilated and it is vertically oval. So the moment you see circumcorneal congestion with such type of pupil, your answer will be acute angle closure glaucoma. Then if you ask me the definitive management, that is going to be laser PI. What is happening? You are doing the laser PI in the involved eye. What will it do? It will create an alternate path for aqueous humor outflow. This has to be done in the involved eye and has to be followed by prophylactic laser peripheral iridotomy in the other eye after 1 week. So this is how you manage. Talking about anterior uveitis, causes include seronegative arthropathy, that is pear, psoriasis, ankylosing spondylitis, inflammatory bowel disease and Reiter's arthritis. Or it can occur after trauma, juvenile idiopathic arthritis, Fuchs heterochromic iridocyclitis, keratouveitis or infectious occurring secondary to TB, syphilis, sarcoidosis. Pain is symptoms is going to be pain, redness, blurring of vision and photophobia. Looking at the signs, you see either cheratic precipitates like this on the back surface of corneal endothelium, or you can have cells in the anterior chamber, or you can have flare in the anterior chamber. Sometimes when these cells are very large in number, they will settle down by gravity, leading to the formation of hypopyon. What is hypopyon? It is pus in the anterior chamber. Then moving on to other signs, you can get these iris nodules. Iris nodules are of two types. It can be either Kopes nodules. P in Kopes, P is pupillary border. C should be the seronegative arthropathy. Pair, it is HLA-B27 positive. So you either say HLA-B27 positivity or you say the seronegative arthropathies. That is the same. Or you can have Busaka's nodules. These Busaka's nodules are present somewhere here on the Busaka's B base of iris. Then what happens is your in anterior uveitis, your iris is sticky, so it will stick onto the posterior surface of iris, will stick onto the anterior surface of lens capsule. So when you try to dilate the pupil, there will be irregular areas of pupillary constriction and dilatation, leading to what you call as festoon pupil. This is your festoon pupil. This is a NEET PG 24 question, so it is highly expected in your FMG exam. Management will be, since there is inflammation, you have to give steroids. Along with that, since there is photophobia, you have to give cycloplegics to relieve the ciliary muscle spasm. Band shaped keratopathy is a common feature in patients of juvenile idiopathic arthritis who have anterior uveitis. Now if you ask me the most common complication of anterior uveitis, it is cataract. And what is the most common complication of recurrent anterior uveitis? My answer will change to secondary angle closure glaucoma. See, KPs can be mutton fat, that is they are very big, or they can be fine. Okay, the third type is the stellate shaped KP. So we have got different type. You just need to know that KPs are a sign of anterior uveitis. Then is intermediate uveitis. What are you going to see? Either you will see these snowballs. What are snowballs? Nothing but clumps of inflammatory cells. Or you can have something like this. What do you call this as? This is your snow banking. When these clumps, when they settle along the blood vessels, you will call it as snow banking. Now, what is the most common cause of loss of vision in intermediate uveitis? It is cystoid macular edema. When this intermediate uveitis it spreads to the retina, it will lead to cystoid macular edema, thereby leading to decrease in the vision. Management will be nothing. Since the site of inflammation is vitreous, you are going to give intravitreal steroids. Moving on to posterior uveitis, just remember 2-3 things. In sarcoidosis, we are going to get candle wax drippings. In tuberculosis, you will get something like this, multifocal serpiginous choroiditis. In CMV retinitis, you are going to get this appearance. What is this called as? This is your pizza pie appearance. So in this you have got white part is the area of necrosis, which you also call as which will resemble the cheese of the pizza, and the red area is the area of hemorrhage that will resemble the sauce. So the cheese and sauce will resemble the pizza, piece of pizza, or you can also call it as sauce and cheese retinopathy. Then toxoplasmosis, you can have either headlight and fog. So toxoplasmosis, you have got two types of toxoplasmosis. One is congenital. So when it is congenital, you are going to get bilateral punched out scar on the macula. So you will see some black scar on the macula. Or in acquired cases, you can have a headlight in fog appearance. See, brush fire is seen in CMV retinitis, not in toxoplasmosis. So toxoplasmosis acquired, you are going to get headlight in fog appearance. If you see here, the fog is compared to the vitritis and headlight is compared to this. What is this? This is the patch of necrosis that you will compare to headlight. Okay. Moving on to Fuchs heterochromic iridocyclitis. This has never been asked, but you should know. Two things. One is stellate KPs. In this KPs are stellate or the star shape. Then is Amsler sign. See, what happens is there is a lot of inflammation in the eye. So whenever you try to do anterior chamber paracentesis, then because of the inflamed iris, there will be hyphema. The eye vessels are inflamed. So as soon as you do anterior chamber paracentesis, there will be IOP fluctuation and there will be presence of hyphema. That is your Amsler sign. If you look at this, there is heterochromia. Heterochromia means iris of both the eyes has a different color. Now moving on to sympathetic ophthalmitis, a very important topic. Risk factor is history of any penetrating injury. This is a previous year question, repeated. History of any penetrating injury or history of intraocular surgery. Pathogenesis, it involves you have got two eyes. The eye with the injury, it will eventually lead to granulomatous panuveitis in the other eye. This is sympathetic ophthalmitis. So earliest symptom is going to be photophobia and earliest sign is going to be retrolental flare. If you ask me the management, nothing. If you are suspecting, if it has, okay. So in sympathetic ophthalmitis, if it has just started, then you can go for enucleation of the eye with the trauma. But if it is full-fledged, that is, it is having granulomatous panuveitis, then go for steroids by all routes. What does that mean? Steroid by all routes means you have to give IV, oral, all types of steroids. Okay. Now moving on to endophthalmitis. Endophthalmitis, I have told you, hypopyon with progressive vitritis. If we look at the causes, early post-op, it is coagulase negative staphylococcus, that is Staphylococcus epidermidis. Late post-op, more than 6 weeks, it is definitely going to be propionibacterium. Endogenous means something from the inside. It is going to be the Klebsiella or Candida. Or traumatic, it can be seen in Bacillus cereus. Management, I have told you, you have to go for intravital antibiotics. Moving on to the corneal investigation. This is a pachymeter which is used to measure the corneal thickness. Normal corneal thickness is 540 microns. This is your keratometer that is used to measure the corneal curvature. This is your Placido disc. What is it used to do? It is used to examine the corneal surface. What is this? This is a pentacam. Pentacam is used to measure the corneal surface. So both pentacam and Placido disc, these are used for corneal topography. You can get all these as image based questions in your exam. Now if we talk about endothelial cell count, we know normally the endothelium has 2400 to 3000 cells. This cell count is done by specular microscopy. Okay, so sometimes what happens is this cell count, when it is between 500 to 2400, what happens is cornea is entering into the stage of decompensation. So when it is entering, so how will the cornea compensate? By undergoing polymorphism and polymorphism. Now see, endothelium has got these cells, normally 24 to 300. Okay, so what happens is, when normally this with age, with every decade, this cell count decreases. Okay, but if this cell count decreases to less than 500, that means the cornea has already decompensated. But if the cell count is between 500 to 2400, that means chance hai that the cornea will compensate. Now, how will this cornea compensate? By undergoing polymorphism means bade cells, and polymorphism means shape change karke. Okay. Moving on to stains of cornea, I have told you this. This is your fluorescent stain. Now, what does the fluorescent stain do? It will stain the epithelial defect. How will the epithelial defect look? I told you fluorescent stain, it is done via the sodium fluorescent dye under cobalt blue filter, and this epithelial defect, how will it appear? It will appear brilliant green. Now this is what you call as rose bengal stain. This is your lissamine green stain. Very important is this rose bengal and lissamine green stain. What will this stain? They will stain the margins of the ulcer. So, can I say that epithelium or the base of the ulcer will be stained by your fluorescent dye, and the margins of the ulcer will be stained by your rose bengal and lissamine green. Done. This is a very important PYQ. Now moving on to bacterial keratitis. That is, what is bacterial keratitis? Keratitis is nothing but the inflammation of the cornea. Okay, so why is it occurring? It is occurring secondary to corneal ulcer. So any ulcer, most common presentation is going to be pain, watering, redness, photophobia. Clinical examination, circumcorneal congestion. There will be fluorescent stain positive. That means ulcer will have an epithelium defect. There is no epithelium. Okay. Along with that, in the stroma there is infiltration. See what happens? कोई microorganism आया, it will come, it will attack the cornea. Once it attacks the cornea, body will send some cells to counteract that organism. Okay, so you will have stromal infiltration. What is stromal infiltration? Nothing but the WBCs of our body that will go, that will act against the organism. Along with that, there is some edema in the stroma. Now in bacterial corneal ulcer, most common cause is Streptococcus pneumonia, but there are certain that penetrate the intact epithelium. The ones that penetrate the intact epithelium are LDH-N2. L is Listeria monocytogenes, D stands for Corynebacterium diphtheriae, H stands for Haemophilus influenzae, and N2 is Neisseria gonorrhea and Neisseria meningitidis. Now the pus in the ulcer in case of bacteria is characteristically sterile. It is sterile and it is immobile. But in fungi it is unsterile and it is immobile. Bacteria it is sterile and mobile. Now whenever the ulcer has been there for long duration, what will happen? Or if there is an increase in intraocular pressure, cornea will thin out and eventually there will be formation of desmetocele, which is followed by corneal perforation. Corneal perforation is characterized by sudden decrease in pain. This is then followed by, see, your cornea is perforated from here. Now the iris will come and attach like this. This is leucoma adherens, and eventually some infiltration, which is pseudocornea, and eventually you will call it as, there will be definitive organization of these cells and all, which you call as anterior staphyloma. If we talk about viral keratitis, there will be history of recurrence and there will be characteristic formation of these structures, which you call as dendrites. Now the question arises is, in exam, what they ask about dendrites is, for the dendrites of the viral ulcer, the margin will be stained by your rose bengal stain and your ulcer base will be stained by your fluorescent dye. Now what is the management of viral keratitis? That is 3% acyclovir ointment. Okay, this is what you need to know. Then if we talk about herpes zoster ophthalmicus, if you are given a patient who has skin lesions on half of the face, what does that mean? Your skin lesions are respecting the midline, they are not crossing the midline, either they are here or they are there. Along with that, the patient is having fever, malaise, neuralgia. Most likely it is a case of herpes zoster, which is seen in immunocompromised patients. And if you look at the corneal signs, it will be microdendrites. Normal dendrites are typically very well defined. Microdendrites are a bit haphazard. Talking about Hutchinson sign. So Hutchinson sign, it occurs because of the involvement of nasociliary nerve. Now, what happens is, they say that if the tip of the nose is involved, then involvement of cornea is there. Why? Because of the nasociliary nerve that will supply both the tip of the cornea and both the tip of the nose and the cornea. If we talk about management is high dose antivirals. Now talking about fungal keratitis, 2-3 important points that you need to know. In question, if you are given a history of vegetative matter injury, close your eyes and mark fungal keratitis. Signs are more than symptoms already. The ulcer will be dry looking. Okay. Margins are fluffy, or what you call as feathery margins. Multiple satellite lesion. That means you have the main lesion and multiple lesions. Then hypopyon is characteristically immobile and asterile. Investigation, any fungal ulcer or any fungal thing, you go for 10% KOH examination or SDA culture, Sabarod, dextrose, acar culture. Or you can even go with the Gomori methinamine stain. What is the management? Definitely antifungals. What is the drug of choice? It is natamycin. Or you can even go with amphotericin B or voriconazole. Margins are seen in bacteria. No, all the ulcer margins are there, right? Wherever you are going to, यहाँ सेंटर में epithelial defect हुआ, तो periphery में margins have to be there, okay? तो margins are stained by a rose Bengal dye and the lissamine green dye, and the base of the ulcer where you have the epithelial defect, that will be stained by a fluorescent stain. Am I clear, Medico Pro? Then is acanthamoeba keratitis. Whenever in question you are given a contact lens using tap water or swimming with the contact lenses on, that means they are talking about acanthamoeba keratitis. But in question, if you are just given only a contact lens wearer develops a ulcer, then your answer will change to Pseudomonas. But contact lens wearer using a tap water or swimming with the contact lenses on, your answer changes to acanthamoeba keratitis. So you have this ring shaped ulcer. In this, pain is very characteristic. Ring shaped ulcer with severe pain, that is characteristic of acanthamoeba keratitis. Investigation will involve calcoflower white, lactophenol cotton blue and E. coli enriched non-nutrient agar. Treatment will be dipropamide and polyhexamethyl biquinite. Keratoconus, what is the association? Association includes Downs, Turners, Marfan's, Ehlers, Osteogenesis imperfecta, VKC, blue sclera, Ectopia lentis. Presentation, repeatedly asked, very important. Patient will have progressive myopia and irregular astigmatism. Scissor reflex, Vogt striae. Now what is Vogt striae? Vogt striae are these vertical. Surbi, cycloplegics we are giving in all the cases of corneal ulcer. Okay, and if it is bacterial, then it is antibacterial with cycloplegics. If it is viral, antiviral with cycloplegics. So corneal ulcer, cycloplegics you have to give, since the pain is there in all the types of corneal ulcer. Vogt striae are the vertical stress lines. Okay, these vertical stress lines that occur in keratoconus. Your eyeball is becoming like this. Okay, so there is stretching and then there will be rupture. So vertical lines will be Vogt stress lines. Then you have Munson sign. So when you ask a patient of keratoconus to look down, there will be a V-shaped lower lid bulging. This is your oil droplet reflex seen in keratoconus. Then you have Fleischer's ring. You have this cone of keratoconus. So Fleischer's ring is F Fleischer's, F iron deposition at the base of cone of keratoconus. If you look at Rizzuti sign is the V-shaped arrow that you see on the nasal retina when you show light from the temporal retina. What will happen? Light will go, it will strike the keratoconus tip and then it will form a V here on the nasal retina. So this is the Rizzuti sign. Then you have Placido disc. This is how you see, I told you Placido disc is used for corneal topography. That means for looking the external surface of the cornea. This is how the normal cornea looks like. But in keratoconus, because of thinning, the corneal circles will be close to each other. This is a case of keratoconus. Then management I told you, firstly you investigate it via pentacam. I have shown you what pentacam is. So if it is progressive, go for C3R. What is C3R? It is collagen cross-linking. This collagen cross-linking, it is done along with UVB rays and riboflavin. Or you can use rigid gas permeable lenses, which you call as rose K lenses, or you can go for Intax. What is Intax? Intax is intrastromal corneal rings. Or if the cornea has got an opacity, then you can go for even penetrating keratoplasty, in which we replace the cornea of the patient with the donor cornea. Talking about corneal opacities, this is a nebular corneal opacity. You are clearly able to see the iris details and the margin of the pupil. Macular, you are clearly able to see the pupillary margin, but iris details are not very clearly visible. Leukomatous opacity, nothing is seen, neither the pupillary margin nor the iris details. Then this is about penetrating keratoplasty. I told you what you do is you replace the donor cornea, patient's cornea with the donor cornea. Now what is the donor cornea? This is how the donor cornea looks like. This is your corneal button. How will you store this? This is your MK media, that is McCarry-Kaufman media. So if you ask me what is the immediate way to store, it can be in the moist chamber up to 2 days at 4 degrees Celsius, or in intermediate cases you can go for McCarry-Kaufman media, in which you can store up to 4 days. But if you want to store cornea for long term, you can go for organ culture or cryopreservation. Sometimes after doing the cornea transplant, the graft gets rejected. Now what are the signs of graft rejection? Remember, there are, number one is Coda dust line. What is this line? So this line is, yes, optisol, cornisol, there are so much, right? They are also intermediate. Cornisol, optisol. But these are not very important. The one that you will get in exam is your McCarry-Kaufman medium, which looks like this. Okay, so we have the Coda dust line. What is it? It is a line of graft rejection that is seen on the endothelium. Okay, basically what are you seeing? You are seeing multiple keratic precipitates on the endothelium. Okay, or you can have is multiple dots on the epithelium also. What do we call that as? You call it as case lines. Okay. So these are the two signs of corneal graft rejection. Now moving on to ptosis, we know ptosis is drooping of the upper eyelid. The one that is important for your exam is Marcus-Gunn jaw winking phenomena. This is a repeated previous year question. So if you talk about Marcus-Gunn jaw winking phenomena, why does it occur? This occurs because of aberrant regeneration of the fifth cranial nerve into the third cranial nerve. So what is happening now? Your third cranial nerve, fifth cranial nerve is supplying the third cranial nerve. So in any situation such as when the child is feeding or sucking thumb, so in any situation when the child uses a pterygoid muscles, what will happen? There will be a transient elevation of eyelid. Okay, there will be a transient elevation, it will come down. Elevation come down. It will appear as if the child is winking. Okay. That is why you call it as Marcus-Gunn jaw. Why jaw? Because it involves the pterygoid muscles and winking phenomena. Management of this is you have to resect the levator palpebrae, remove the levator palpebrae, and along with that go for a frontalis sling operation. What are the other options available for ptosis surgery? We can either go for fascinella cervet operation. This is done when the ptosis is mild. Levator resection, it is done when the LPS action it is good and the ptosis is moderate. Sling operation is when your LPS action is bad. Then what you do is you remove only. You don't use that for surgery and your ptosis is severe. So what you do in sling operation, you are basically elevating the eyelid by passing a sling here from the frontalis muscle. Okay, so they can ask you in sling operation what is the muscle in which is helping in elevation. Now LPS is not helping, frontalis muscle is helping in sling operation. Now entropion, this is a repeated thing, or I would say a repeated image based question. You see the eyelid margin has turned inwards. What is it leading to? The eyelashes are touching the cornea. What is this called as? This is called as trichiasis. Okay, and this is your entropion. So how will you correct it? You can correct it by J.W. Marriott. Now J is Jones operation, W is V's operation, M is modified Wheeler's operation, and T is transverse lid everting sutures, which you also call as Quickert's sutures. So in all the cases, what are we doing? We are strengthening the retractor muscles of the eyelid so that the eyelid that has gone inside will now retract like this. Okay. Then this is your ectropion. What are you going to do? You are going to do BLS, basic life support, Bryan Smith operation, or lazy T procedure or scar tissue excision, and you are going to do a VY-plasty. Sometimes this is scar here, maybe because of trauma or any burn, that will pull the lid. When the scar heals, it will lead to fibrosis and it will pull the lid downward. So you have to excise that scar tissue and do a VY-plasty, that is BLS or basic life support. Another very important this year, July 2026 question also, 25 question also, previous year, on STI. So what is STI? STI is characterized by inflammation of glands of Zeiss. Chalazion is characterized by inflammation that is chronic and lipogranulomatous of the meibomian glands. So if we talk about STI, it is here. Basically the glands of Zeiss, these glands are present at the base of hair follicle. Now, since it is here, it is painful, it is present at the lid margin. Very important. Painful, present at lid margin. How will you manage it? You will manage it by hot compression and antibiotics. Chalazion, it is not painful and it is located away from the lid margin. Very important. Management is going to be incision and curettage. What is the most common complication of chalazion surgery or chalazion assay, such as it is recurrence. Okay. So how will you treat this recurrence? You will treat this recurrence by giving intralesional triamcinolone. That means intralesional, you are going to, if you give steroid, then the chances of recurrence also decreases. Moving on to errors of refraction. Hypermetropia, and you will know that infant is hypermetropic by 2 to 3 diopters. Hypermetropia is also known as long-sightedness. So basically the eyeball is short in this. Symptoms are mainly going to be asthenopic, such as headache. Patient will have headache, difficulty in focusing for near. Signs will be shallow AC and pseudopapillitis or the silk short fundus. Patient of hypermetropia is predisposed to recurrent styes, chalazion and angle closure. Why stye and chalazion? Because whenever there is heaviness and the patient is having asthenopic symptoms, so the child will have the tendency to rub the eye, and when the child will rub the eye, nobody knows whether the child is harboring any microorganism or not. So if the hands are dirty, then it will lead to infection leading to stye and chalazion. Then is aphakia. Aphakia is the absence of crystalline lens. Now we know that the total dioptric power of the human eye is 60 diopter, out of which 43 to 44 diopters is contributed by cornea and 16 to 17 diopters is contributed by lens. So whenever there is aphakia, this 16 to 17 diopter is absent. So it will lead to high degree of hypermetropia. Power I have told you will be reduced to 43 to 44. There will be no accommodation, since accommodation is also occurring via crystalline lens. So symptoms will be erythropsia, synopsia. Signs will be limbal scar, deep AC, iridodonesis, jet black pupils, and only 2 Purkinje images. And then you will have jack-in-the-box and roving ring scotoma. Myopia, very important. So patient of myopia has a long eyeball and the patient will have a problem with the far vision. So you also call it as short sightedness. Symptoms, muscovolitentious means the patient will feel something moving inside the eye, and night blindness in late cases. If you look at fundus, there will be this peripapillary atrophy, or there will be Foster Fuchs spots here. What is Foster Fuchs spot? It is an area of hemorrhage. Why is it occurring? It is occurring because the eyeball is long, everything has stretched, even the blood vessels have stretched. It is an area of hemorrhage at the macula. Then what happens is everything is stretched, so there will be more visibility of choroidal blood vessels. So there will be tigroid fundus, lacquer cracks are here. Lacquer cracks are your breaks in the Bruch's membrane. Then there will be posterior staphyloma, Weis reflex, and the lattice and snail tract degeneration. So this is an important question. Now complication, it can lead to retinal detachment, myopic CNVM, and complicated cataract. Management involves diverging lenses. So we have to decrease the power of the eyeball by using diverging or the concave lenses. Astigmatism, this is your July 2025 image. What is this? This is seen in astigmatism. What is astigmatism? When the power in the two corneal meridia is different. Suppose the power of this axis is more than this, or power of this axis is more than this. So that is when you will call it as astigmatism, and this is what you call as Sturm's conoid. What is Sturm's conoid? They say whenever the light reflects from a toric surface, a conical structure like this is formed, in which at say B point, what will happen? The rays from one meridia will focus, and at E point, the rays that are coming reflecting from the other meridia, they will focus. So this is what you call as Sturm's conoid, and this part is referred to as the focal interval of Sturm. Okay. Now, astigmatism can be regular. In regular, what we have is with the rule, against the rule, or oblique astigmatism. Remember, cornea has got two meridia. In with the made up of two V, right? So, in with the rule, power in the vertical meridia is more than power in the horizontal meridia. Against the rule, power in horizontal meridia is more than power in the vertical. Oblique, there are two axes that are at an angle of 90 degree to each other, but these axes are not 90 degree or 180 degree. Suppose one of them is 45 degree, other is 135. So still they are perpendicular, but neither of them is 180 and 90 degree. Then there are different types of astigmatism. Simple myopic. Simple means one axis focuses on the retina. Myopic means eyeball is long, so the rays will focus anterior to the retina. Then simple hypermetropic. Voice problem. नहीं चल रहा है. Okay. Okay, great. So what happens in compound type of astigmatism? Both the axes, they will either focus anterior in cases of myopic or posterior in cases of hypermetropic. Mixed means one axis will focus anterior to the retina and the other axis will focus posterior to the retina. Then How will you tell about astigmatism? So astigmatism can be told by, this is astigmatic fan test, and this is Jackson cross cylinder test. Okay. Now irregular astigmatism, that was regular. Irregular can be because of cornea or the lens, as in it can occur in patients of keratoconus, or it can occur in patients of retinal scarring. Then you have anisometropia, that means there is a difference in the power of two eyes. So anisometropia is, this is not there, when the difference in the power of two eyes, it is present. Normally we can tolerate up to 2.5. When it is more than 2.5 diopters, it will lead to amblyopia. Then is anisoconia. Anisoconia is the difference in the image size of the two eyes. Okay, so they say that whenever you are having 1 diopter power difference between the two eyes, that will lead to 2% difference in the image of the two eyes. So for 2.5 diopter, that means our eyes can easily tolerate up to 5 diopters difference in the size of the image. More than that will lead to diplopia and confusion. Now is accommodation. Accommodation is the ability of the eyes to focus the diverging rays that are coming from a near object on the retina in a bit to see clearly. So this, we know that lens is suspended by the ciliary zonules that are coming from the ciliary muscle. This is a unaccommodated lens. But in accommodated lens, what happens is the ciliary muscle will contract, that will lead to curling of the zonules, which will lead to the tension into the lens, tension in the lens, and that will make it more round or more globular, thereby helping in accommodation. Then is presbyopia. Very commonly our given statement is presbyopia an error of refraction? No, presbyopia is not an error of refraction. So what is presbyopia? Presbyopia is nothing but age related hypermetropia. So how will you treat it? You will treat it via convex lenses. Then is retinoscopy. Retinoscopy, we know it is done to calculate the refractive error of the human eye. This is Priestley Smith mirror retinoscope. This is a streak retinoscope. So what are you doing? You are looking at the movement of the red reflex. So no movement means myopia of 1 diopters. With the movement means either emetropia, hypermetropia, or myopia of less than 1 diopters, or against the movement means myopia of more than 1 diopters. So what are the drugs that you use? In children you can either go with atropine or cyclopentolate, and in elderly you can go with homide. Now WHO categorization of visual impairment. WHO says whenever the vision is less than 3/60, or the patient is not, whenever the best corrected visual acuity in the better eye, it is less than 3/60, or the patient is not able to count fingers at a distance of 3 meters in daylight, or when the visual field contraction is less than 10 degree, that means the person is blind. What are the causes? Most common is cataract, then you have refractive error, corneal opacity, glaucoma, and vitamin A deficiency. Xerophthalmia, what happens is there is decrease in the number of conjunctival goblet cells that will lead to dryness in the eye. Why is it occurring? This is occurring because of vitamin A deficiency. So we have a classification for that. XN is night blindness, X1A is conjunctival xerosis. This is what you call as Bitot spots. X2 is corneal xerosis. This is corneal xerosis. X3A is corneal ulceration. This 3A is when it is involving less than 1/3 of the corneal surface and more than equal to 1/3 is X3B. XS is corneal scar and XF is xerophthalmic fundus. Now management for dryness, go for lubricants. For keratomalacia, you have to treat it like a corneal ulcer. And vitamin A therapy, 0 to 6 months you are going to give 50,000, 6 to 12 months 1 lakh international units orally, and more than 12 months 2 lakh international units orally. IM dose is always half the dose of oral in all the age groups. Then if you talk about the prophylaxis, the dose remains the same, but it is given only once, and in therapy it is given on day 0, 7 and 14. Now talking about direct versus indirect ophthalmoscopy. This is your direct ophthalmoscope and this is your indirect ophthalmoscope. Indirect ophthalmoscope visualization is up to the equator. Indirect, you can visualize it up to ora serrata. Magnification is 15 times in direct ophthalmoscope and it is 4 to 5 times in indirect ophthalmoscope. Image in direct ophthalmoscope is virtual and erect. It is real and inverted in indirect. Direct ophthalmoscope cannot be used in hazy media. Indirect is useful in hazy media. Direct will visualize just the central 10 degree. Indirect will visualize a bigger part 30 degree. Stereopsis is present in indirect ophthalmoscope. Now then you have two things, that one is ERG, other is EOG. So whenever the light rays they fall into the retina, there is an action potential that is generated. To measure that action potential that is generated in response to light is what you call as ERG. So what is the source of ERG? It is pan-retinal. We have got three waves. A wave, it is negative because of photoreceptors, that is your rods and cones. Then you have B wave, it is a positive wave that occurs because of the bipolar cells. And then you have a C wave that occurs because of retinal pigment epithelium. Then you have EOG. EOG is what? It is another investigation that measures the standing action potential between the cornea and the back of eye. It is measured in the form of Arden's ratio, that is calculated as light peak to dark trough. Normally it is more than 1.85 or 185%. Another thing is VEP. What is VEP? VEP is visual evoked potential. So this again says that whenever your light rays, it falls onto the optic nerve. So what is the amount of action potential that is generated in the optic nerve? That is what you call as VEP. Okay. Now what is this? This is your Snellen's chart, and this is a Snellen's distance chart. Basically it is used to look at the visual acuity for the distance. So it has got multiple lines. So what we do is ask the patient to close one eye and start reading from top to bottom. Suppose the patient reads the first line, we will write it as 6 by 60. So what does the numerator stand for? It will tell you the patient's value. And 60 stands for a normal person value. What does that mean? That means this A or the topmost line, what a normal person can read from 60 meters, that this person can read only from 6 meters. Another thing is, this is done at a distance of either 6 meters or 20 feet, this test. Okay. So 6 by 60 is this. Then if the patient is not even able to read 6 by 60, what we do is we decrease the distance. Okay, at a distance of 5 meters, then we do it at a, if still not able to read, then we ask the patient to read Snellens at a distance of 4 meters, then 3 meters, then 2 meters, then 1 meter. Even after 1 meter, if the patient is not able to read, then we will do finger counting. Even if after the finger counting patient is not able to read, then we will do ask whether the patient is able to look at the hand movement or not, and after that we will look for the perception of light and projection of rays. And if the patient is not even able to tell this, then we say that the patient is blind. Another thing, another important MCQ that is asked, what is the angle subtended by each of this letter at the nodal point of the eye? So they say that the angle subtended by each letter from its respective distance at the nodal point of the eye is 5 minutes of arc. So this is the angle that each letter will subtend from its respective distance. Now what is this? This is another chart for measuring distant vision. This is a C ring test chart. This is E, tumbling E chart. This is the Jaggers or the Snellen's near vision chart. This is a K picture chart used in children. This is Jogren's hand test, again used in children. This is a lighthouse test, again used in children. Now moving on to some instruments quickly. This is your glaucoma shunt, which is used in trabeculectomy surgery. Basically glaucoma express shunt. This is your applanation tonometry. This is your wire vectus used in cataract surgery. This is your, if you look here, this has got tooth. This is known as superior rectus holding forceps. This diamond shaped structure is what you call as keratome. This is a wire speculum. What will this do? During any surgery you have to open the eye. So this will help in opening up the eye. This is your IOL holding forceps. This is your Simcoe cannula. What will it do? It will help in irrigation and aspiration of the cortical matter. This is your IOL dialer. This is your IOL injector. When we do phacoemulsification, the size of the incision is very small. So we roll the lens inside this and we inject it into the eye of the patient. So as soon as you inject it, the IOL will open up inside the eye. This is a Calazion clamp. This is a enucleation or optic nerve guide. This is a evisceration curate. It is bigger, okay, but if you have a very small curate like this is a Calazion curate. This is a lid clamp. This is a lid spatula. These are the corneal trephine. What is corneal trephine used for? It is used to make the corneal button. I showed you corneal button that we were keeping in MK media to preserve it. So this is used to make corneal button of the donor cornea. This is your trabeculectome, used for trabeculectomy surgeries. Lectome. I told you we do trabeculectomy and trabeculotomy in children of congenital glaucoma. In adults also we do trabeculectomy, but this trabeculotome is used in trabeculotomy. Otomy means you are just making a hole. So this is sharp. This is used to make holes. Then these are the Bowman's cannula. What are these used for? These are used for probing. As I showed you, probing of the lacrimal sac. This is your puncta or the punctum dilator. This is your bone punch. Where do we use this bone punch? This is used in DCR, dacryocystorhinostomy. So this is used to punch the bones. So there was a question once in FMG in which they asked what are the bones that are punched. So the bones that are punched are lacrimal and ethmoid. So this was all about the MAHA revision of ophthalmology. I hope you liked the session, and in this I have either maximum I have given you previous year questions, expected questions, the important topics, and if there is a problem you people have faced anywhere, you can revisit the channel and you can view it, since it will be stored also on the channel. And all the very best for your exam. Try to understand what the question is asking and then moving on to the options, rather than straight away moving from the options to the questions. And this was all about ophthalmology. So see you people on the other side preparing for NEET PG, and wish you all very best. Okay, have a great day. Keep revising all the subjects. It's the last leap of your exam. Okay, bye. Enjoy.